Good morning, everyone. I hope I'm audible. So I'm Dr. Moses Opondo. So welcome to the Indo-Africa Congress today. I think now you're coming to the final day for those who have been with us from the Wednesday. So today we are going to do cardiology series for the Indo-Africa Congress. And our team is already here. They're ready to share with us the knowledge. I know they have vast experiences in different fields of cardiology. So I'll welcome the two of you to join us on the platform. I'll introduce each one of those individually when you have started. All right. You can just have a seat this other side. Thank you. So Indo-Africa Congress, again, just a reminder, is a partnership between doctors from India subcontinent and Africa continent. So it's really a partnership which the plan is to grow it globally, to share knowledge in our medical field so that we can learn and teach each other. And even for those who have interest in different fields of medicine, I can choose where they want to specialize in future. I know many different people in this room, so all of you are welcome. So today we are going to focus now on the advanced technologies in the field of cardiology and cardiothoracic surgeries. So we have in our panel here, we have a cardiologist and we also have a cardiothoracic surgeon. So the first talk today is going to be given by Dr. Deepak Thakur. Dr. Deepak Thakur is a pediatric cardiologist. Sorry, just a minute. So he's a pediatric cardiologist from India who practices at Paras Hospital with experience for the last 15 years. So he has a very keen interest in the field of pediatric cardiology. Currently, he also has experience in neonatal cardiac evaluation and echocardiography, adult congenital heart disease, and cardiac evaluation and echo, 3D echo, fetal echo, transesophageal echocardiography, diagnostic and interventional cardiac catheterization. All this, he has built his knowledge by doing a fellowship in pediatric cardiology, finishing in 2021, being an associate consultant. So welcome, Dr. Deepak Thakur. He's going to give us his first talk on intervention in complex structural heart disease from neonatal, fetal, neonatal, pediatric, and possibly even to adulthood. So we are looking forward to your talk. I know it's a very complex talk, very vast topic, but please share it in a few minutes in a simpler way so that you can understand whatever you're doing. Thank you so much. Welcome. Let's give him a clap.
Yeah. Thank you very much for the warm welcome. Thank you for introducing me. I'm Dr. Deepak Thakur, a pediatric cardiologist and structural heart disease interventional cardiologist, working as a senior consultant in Paras Hospital, Gurgaon, India. I welcome you all to today's Advanced Cardiac Interventions and Cardiac Advances CME. And we'll be starting first with the first lecture will be on the interventions in complex structural heart disease. Can you please play the slides? Yeah. So when we talk about interventions in complex structural heart disease, what do we mean by structural heart disease? Structural heart disease are the defects in the heart which are related to the structural formation of the heart. It can be a hole in the heart like an ASD, VSD, PDA, or it can be a blockage in the valve like aortic stenosis or pulmonary stenosis, or it could be some sort of an abnormal connection like coronary cameral fistulas, and then it could be in cyanotic congenital heart disease, babies or even adults. It could be an abnormal connection between aorta and to the lungs. We call it as large MAPCAs or major aortopulmonary collaterals. So these are kind of the structural heart diseases that we come across in our daily practice. And we deal with newborn babies right from birth till adulthood. So any structural heart disease that comes to us, it's very important before you do intervention in the structural heart disease, a proper evaluation of your patient. What are the symptoms? What is the natural course of that disease? Does that patient requires intervention, or we can medically manage that patient? Or does that patient requires more than intervention, a surgical treatment or a cure which we can offer to the patient? We always try to give a one-stop solution, a single intervention which can solve all the problems for the patient. But yes, of course, there are much more complex congenital heart diseases which does require repeated interventions. So I'll be presenting some of the challenging cases in treating the complex structural heart diseases. I deal with pediatric as well as adult. I'm a pediatric cardiologist, but I do adult structural work also. So in today's talk, we will be presenting both the pediatric and adult. I'll be talking in between about the latest advances that has come up in devices which are available nowadays, where we can do the intervention in the small babies also, where earlier they used to go for surgical corrections. Can we play the slides, please? Okay, I think there is some technical issue. Till it starts, I would like to know how many here are residents who are doing their undergraduation. I suppose everyone is resident here. Do we have any cardiologist in the crowd? Any junior cardiologist or someone who's interested in cardiology? Okay, fine. I hope so after my lecture you will develop the gist of becoming a pediatric cardiologist. I'll try my level best to give, motivate the crowd here to pick up this field. This is a very challenging field, trust me. But when you treat a baby and the baby goes home with a disease-free heart, the feeling which you will be having will be way beyond expression. So the first case is delivering cure the minimally invasive way. So here we had a 2-year-old baby who was 8 kg and presented to us with complaints of inadequate weight gain and recurrent chest infections. On clinical examination, cardiovascular system shows normal heart sounds with the S2 wide fixed split and a soft ejection systolic murmur at the left upper sternal border. Kindly play the video, please. We went ahead, we did an echocardiography, and we can make out there was a hole in the heart between the upper 2 chambers of the heart. So this was the hole. So on measurement, the hole was, kindly play the second video also. So we can see the color crossing here on the echocardiography, and we can see the 2-dimensional dropout in the interatrial septum. That was around 10 mm hole in the heart. So basically, babies less than 10 kg and having a 10 mm hole in the heart, it's always become challenging to go for intervention and close these holes. So here comes the point which I was emphasizing earlier. A proper pre-procedure evaluation is very important. So to put a device, a good knowledge about what device I'm going to put here, what are the disc of the device, how much length do I have, how much margin do I have in the heart to place the device without causing any harm to the child and closing this hole completely. So a proper evaluation of the complete structure of the heart, and of course a discussion with your primary team, the anesthetist, the cardiac anesthetist, and of course a backup of a cardiac surgeon is always gives you an extra confidence to go ahead and do the device closures. So we went ahead. Kindly play the video, please. Okay. So this is the device which we deploy. We have taken through the sheath. So this is the device we have deployed across the defect. And after deploying this device, evaluating with the transesophageal echocardiography and properly positioning the device in a location and pulling and seeing the stability of the device, then only we release the device. So we could close the hole in this small baby less than 10 kg with the, an ASD occluder device. This was an atrial septal defect. And yes, of course, with the advancing technology, we are coming across the newer delivery systems which are available nowadays, which makes us feel much more confident in deploying the device. So here also we can see the bend in the wire was there. So this bend basically helps us in seeing the accurate position of the device. There is no pull in that. Previously, the earlier wires which used to come used to give the pull on the device. So it was always difficult, and cardiologists used to feel a little underconfident in releasing the device, especially in the small weight babies less than 10 kg. If we have properly evaluated for the deployment of the device, these kind of hardwares which are coming up nowadays and a good knowledge about these hardwares definitely helps you in performing these complex interventions. So the next case is about the intervention in a PDA. PDA is patent ductus arteriosus. It is also a kind of a heart disease. So there is basically a connection between the aorta, the main vessels which supplies the blood to your body, and the vessel going to the lung. So a connection between them which has remained after birth. It is present in the fetus life, but it closes by a maximum 3 months of age. If it doesn't close, we call it as patent. It is a ductus arteriosus which has remained patent. It didn't close. So what happens because of the patent ductus arteriosus? There is a load on the heart. There is a volume overload on the heart and the pressure overload on the lungs. So usually the large PDAs can present very early. So we had this baby who was 4-year-old, 3 kg. Again, the history was inadequate weight gain, recurrent respiratory tract infection. He had multiple admissions in the hospital for bronchopneumonia since birth. A 4-month-old child with a multiple admissions in the birth, the indication was there definitely. And cardiovascular system was showing the classical continuous murmur in the left upper sternal border. The pulses were bounding on physical examination. We went ahead, we did, kindly play the video. We went ahead, did an echocardiography. We can see there was a connection. This red color flow, what you can see, this is the connection between the aorta and the pulmonary artery. So we went ahead. So the complexity in this case was that was not a very simple PDA. It was a complex type D PDA. There are certain classifications of PDA. Type A is the commonest and the simplest to close. That is conical PDA. But in this particular case, we had a type D PDA, which is a complex PDA. It has got constriction at both the pulmonary end and the aortic end. Now, so there was a connection here. So this was type D PDA here. We had to form an aortopulmonary loop and then deploy the device. So this is the atriovenous loop we have formed because we had to cross from the aortic end. Then we deployed the device. The device was deployed there. This is the device which we are deploying across the PDA. And then we have taken a check angio, which shows the complete obliteration of the defect. So, I think we are jumping. I think the slides have jumped. So this is the result we get usually. So that baby which came to us was completely failure to thrive case, very thin built baby. And you can see within 3 months, this was the baby on the follow-up in our OPD. This is the miracle these interventions can do in small babies who are coming to us with severe failure to thrive and cases of congenital heart diseases. So coming to the next intervention, this is ventricular septal defect. Ventricular septal defect is a defect between the wall, between the lower two chambers of the heart. We call them as ventricle. There is a septum between them. And when there is a hole in that particular septum, we call it as a ventricular septal defect. We call it as a defect. So nowadays, again, low birth weight or the small babies earlier used to go for surgeries. With the advancement in technology, nowadays we have got advanced devices which can go through a small size pipe to reach the heart and deploy the device. So this case was also a small baby, around 7-month-old with a large perimembranous VSD. So this was the left ventricular angio. We are using a pictal catheter. So here we can see the shunt across the VSD. This particular chamber is getting filled. And this is the wall, interventricular septum. So we went ahead, Kindly play the video, please. Yeah. So we went ahead, we took the device from this sheath, from the aortic end. So it was a low profile sheath because the baby weight was low and this device could easily go from this sheath. We deployed this device inside the heart across the ventricular septum to close this hole. Once confirming it on transthoracic echocardiography, we release the device. So these are, yeah. So this is the latest device which has come up, the Konar MF device. So we can see very well, we can introduce this device to very small sheaths. So sheaths are the delivery systems which we take through the baby's vessels into the heart to deploy these devices. So the smaller the size, the trauma to the vessels of the baby is minimal and the complication related to your vascular injuries are bare minimum. So these are the some of the recent devices we are using a lot in our hospital nowadays to give the best result to the baby. And the wonderful thing is we can deploy the device from both the ends, from the antegrade as well as retrograde side. From both the ends we can hook the device and deploy it easily in the ventricular septum. Then coming to a pediatric cardiac emergency. So that is a case of pulmonary atresia. So this is like an emergency in adults, like, you know, heart attack. STEMI we call it as ST elevation myocardial infarction. So those are the emergencies in adult. In pediatric, this is one of the emergencies, and these babies can be easily salvaged. So what is this kind of defects? So pulmonary atresia is a state in which this vessel, which you can see going to the lungs, this vessel outflow is not formed at all. So the lung is not receiving blood flow from the heart. So if the lung is not receiving the blood flow from the heart, the only way the baby will survive will be through this particular connection. We call it as a PDA. So especially in the cyanotic babies, because the oxygen content of the body is low, the CO2 content is high, they are always in the propensity for this particular ductus arteriosus to shut down. And that can be lethal for the child because this is the only vessel which can keep the baby alive. And yes, of course, these babies comes to us as a newborn emergencies. Right immediately after birth, the baby has turned absolutely blue. The oxygen saturation is not picking up even on ventilator support or oxygen support, whatever you are giving the baby. But the oxygen saturation is remaining way below 80% and it becomes an emergency to keep this particular vessel open. Now the ways to keep this vessel open are two: medical and intervention, and third is by surgery, of course. So if we go by the medical management, the prostaglandin is a drug we use to keep this ductus arteriosus open. But the prostaglandin we cannot use for a long time because it has got its own adverse effects, right? So the other options we have to keep it open, either to put a stent in this, that is by interventions, that's what the pediatric cardiologists do, or in case we are not able to put the stent, or the PDA is complex kind of a PDA, or the baby is very small and doing the intervention through these vessels are going to injure the baby, the vessels of the baby, then we go for surgical operation, in which we make an artificial shunt from one of the vessels from the aorta to the pulmonary artery. That is done by our surgeon, Dr. Mahesh. So I'll be presenting some of the complex ductal stenting cases we have done in our institute. So we are doing ductal stenting antegradely through the venous route. We, in cases where there is a VSD, like this, hole in the heart, we go into the aorta, reach near the ductus arteriosus. So this diagram will explain you. So we identify the ductus. So this is almost getting blocked now. You can see here it is completely cut off from the aorta. We went ahead, we were able to cross the ductus arteriosus, and here we are deploying the stent here in the ductus arteriosus. So after deploying the stent, you can see the position of the stent is nice, and now the blood flow is excellent. The lungs can take a lot of blood here, and the babies can get saturated in these kind of intervention up to 85%, which is good for organ development as well as survival of the baby before we go for final palliation. This is kind of an emergency procedure we do. So final repair is usually done at around 1 year. The stents do work nicely for 1.5 years. After that, we can go for complete repair. We close this hole of the heart and we make an artificial connection between the chamber of the heart, which carries the deoxygenated blood, to the lung vessels, pulmonary artery. So this is one such case. There are many more like that. So this was also a completely obliterated ductus arteriosus. Here we have come from the femoral artery. We have used a low profile catheter, and then after crossing the ductus arteriosus, we took the stent in the position and deployed it, dilated the stent nicely, and the flow to the lungs were excellent. We had good result. This baby also we salvaged. This also came as a newborn baby. Yeah, okay. So, so another neonatal emergency which we come across at our center are cases of the babies are sent as a case of dilated cardiomyopathy. So from the cardiac point of view, they need an evaluation from us. As a pediatric cardiologist, I always look at the arch of the baby because the arch narrowing or arch stenosis is one thing which is going to give the back pressure on the heart and make the heart muscles weak, and then the child can go into a dilated cardiomyopathy kind of a state. So I think the videos. Okay. Don't play the video, please. Don't play the videos. Just show. Just show the video. Show the. No, I think. Okay, leave it. Anyway, so there was a blockage in the vessel of the heart, which we dilated with the balloon, and we can see the result. The vessel got open clearly. There was a complete blockage here in this vessel, and we have to come from the carotid of this small baby. So we use low profile sheets to enter the carotid and dilate this particular area where there was a blockage. This is a balloon we have used to dilate this area, and the result was fantastic. We were able to open this complete track and the baby was saved. And pediatric cardiac interventions is not just about putting the balloon, stents and device. The pediatric cardiac intervention requires lot of pre-procedure workup and the post-procedure care of small babies. They are not like adults. They don't have much reserve. We have to take care of their temperature, their ventilation, adequate monitoring of aseptic conditions we have to maintain. During intervention, we have to take warm saline to let the baby maintain the thermodynamics, because any decline in the temperature, the babies can go into bradycardia or keep on developing their lactates. Your inotropes are not going to work on that particular heart. So it is very important for a pediatric cardiac intervention or surgeries to treat the baby as a whole, not just the heart disease. So this was another pediatric cardiac emergency where there was a blockage in the vessel going to the lungs. We crossed that blockage using the wire, and then we so we balloon dilated that wire. So we use a buddy wire technique in which we take two wires across. The one wire is to take the balloon, the other wire is to support that particular balloon. So we do a buddy wire technique and do a balloon dilatation. This was a case of critical pulmonary stenosis where we dilated it, and the results were fantastic. The pulmonary valve opened completely and the flow to the lungs was established and the baby was saved. Yes. So this is a case of tetralogy of Fallot, TOF we call it as, with a large complex MAPCAS. As I was telling you, this is also a kind of a congenital heart defect where there are large vessels. Kindly play the video. Yeah. So you can see this is the aorta. When we are giving the dye in the aorta, we can see the large vessels which are filling the lungs. So these are abnormal vessels, right? The vessel to the lungs should go from the heart. That is pulmonary artery. But along with the pulmonary artery, there were large collaterals which were supplying blood to the lungs. And this was a case of tetralogy of Fallot where there is a large hole in the heart, the VSD, and the vessel going to the lung is blocked. There is a severe pulmonary stenosis. And as the babies grow, so the body takes a natural tendency to develop more vessels to supply blood to the lungs to maintain the saturation of the body. But these are of course the weak vessels which can rupture anytime and cause the pulmonary bleed. And number two, before surgical repair of these defects, we close these vessels so that post-op or intra-op we don't have much complications in handling the intracardiac repairs. So we went ahead. Kindly play the video, yeah. So we hooked that particular MAPCA. You can see it's a huge MAPCA which was supplying the blood to the whole heart. We use a telescopic technique in which we keep a catheter at the ostium. We take the microcatheter, deploy the coil in a way that the maximum density of the coil remains at the bifurcation point where it was supplying both the collaterals. So hooking the coil is the major objective of talking about this complex MAPCA interventions, because if you don't hook the coil can always jump with the aortic pressure into your descending vessels. I mean the femoral artery or even some small vessel in the leg and can cause limb ischemias. So it is very much, you have to be very vigilant when you are deploying this device. You have to hook it properly as distal as possible in the MAPCA. Using a microcatheter, here I have hooked this particular coil, then you can deploy the remaining coil at the division part and you can block the flow. So you can see post deployment, the flow was diminished significantly. It takes around 10 to 15 minutes time for the epithelium or some clot to form over it and block it completely. So similar case, the same baby had another large MAPCA which was coming from the vertebral artery. That was a contributor from the vertebral artery. Here also we have deployed the coil and the result was fantastic. It was a huge MAPCA which was supplying the blood to the right lung. And the point which I want to emphasize here is when we are deploying these coils, try to go as distal as possible into the MAPCA, as distal as possible from the primary vessel, so that you don't block the primary vessel, which is essential for the baby or for the patient to survive, right? If I block a vertebral vessel, definitely he'll go into paraplegia. So these are not very simple procedures. These are complex, definitely. And you should be well versed with your hardwares. You should be well versed with what kind of coil and what length and diameter you are using, so that you can achieve an adequate result without causing any harm to the child. So adult structural heart defect. So this was an adult with a large PDA. Kindly don't play the video, don't play the video. So in this particular case, in adult PDA, it is always very difficult and it is always very challenging, because technically you have to suspect that any patient who's more than 50-year-old is going to have the vascular calcium deposits or calcification of the vessels will be there. So any foreign body we are using here or deployment of any device, you have to be very precise and accurate what size you are using, because putting an extra large device in these defects or doing too much of manipulations can rupture that particular vessels because it is already calcified. So ductus arteriosus is also a vascular connection between aorta and PA. This particular patient, we could already see some calcium deposits were there in the aorta. And this case also, we were very vigilant. We used very small catheters and wires not to manipulate that PDA and cause any harm to the patient. And then we deployed this particular device to get a fantastic result. And we accurately used the device with an appropriate size, not to oversize it, to cause no harm to the patient, because it can become a catastrophic emergency in case that device ruptures that vessel. So this is also an interesting case. A 32-year-old adult came with dyspnea on exertion and intermittent chest pain. ECGs were showing lateral lead ST changes, and echocardiography, we suspected a large fistula from the left coronary artery going towards the pulmonary artery. Can you play this? I think this will also get rotated. Yeah. Anyway, so this is the left coronary artery system which is coming out. So here we can see the lung fields are getting filled up. So the coronary artery was throwing a fistula into these bronchial arteries. These were not pulmonary artery, but the drainage was into the bronchial artery, and it was quite a significant shunt. Don't play this video, please, it's okay. So we went ahead, we took the best possible view where we can delineate that particular MAPCA, and then we crossed that collateral through the coronary artery, keeping the guiding catheter at the ostium and using the microcatheter to cross and enter into that fistula, which was giving the blood supply to the bronchial artery, an abnormal connection. So, and of course, after the angiography, the clinical feature and ECG findings were matching with our angiography. The fistula scan caused the diastolic stealing of blood from the coronary arteries and can give ECG changes on exertion as well as chest pain, a kind of an angina. don't play the video please, it's okay. So we took the coil and we went as distal as possible, because doing interventions in coronary is not very safe. Again, you have to be very vigilant when you are doing it. You have to be very speculative in what kind of catheters or devices or coils you are taking in, because blocking a coronary artery can cause death on table. So keeping the minimal loops as minimal as possible and taking the coils through these which was a major coronary cameral fistula. We deployed the coils and the result was fantastic. The flow to the lungs was completely obliterated. So selecting what size of the coil you're going to use, the length of the coil you're going to use, and the area of deployment to obliterate it completely is very important when you're dealing with these complex coronary cameral fistulas. So how early can we detect these congenital heart defects or the structural defects of the heart? And then the answer for this is, of course, during the fetal life. When the baby is inside the womb of the mother, the best time to detect these congenital heart defects is between 18 to 22 weeks of gestation. We can get an echocardiography done for the baby inside the womb of the mother. It is done. Our center, we have got a good, kindly play the video. So in our center, we have got a quite advanced fetal cardiology program also, where we are doing the fetal echocardiography. We detect a lot of complex congenital heart disease. This was detected recently. This moving structure is the heart. Fetal echo is also not very simple procedure, because the babies keep on moving. You cannot hold the baby inside. So you have to catch the heart, follow the septums, follow the chambers, everything. So you can see two big holes were there in the heart. One was between the lower chamber, one was between the upper chamber. And one of the chambers was smaller than the other chamber, the main chamber. And the vessels were also coming abnormal. The aorta was coming from the right ventricle. It was supposed to come from the left ventricle. So it was a complex congenital heart disease we detected right at the fetal life. What advantage we get detecting these congenital heart defects so early? We can always give the option to the parents. If we know that the child is not going to have a very fruitful life or going to have a very limited life span and will require multiple surgeries, we do give the option to the parents. If they want to salvage, we can operate the child. If they want to go for termination, they can go ahead and go for that. So detecting these very early does help. And then, of course, we can go for the test, genetic studies of that fetus to see what are the chances that the other child, the next child, is going to have what percentage of chance that he might also have this kind of a congenital heart defect. So this was another fetus. Kindly play the video. So this was a case of ventricular septal defect. In simple heart defects, we don't advise for any termination or give an option. These are the kind of heart defects which require one-time treatment, and the baby can have absolutely normal lifespan. Just like us adults, he can live a normal life, and with advancing age, he'll be able to do all his activities. This is just one-time intervention. We require either surgery or a device closure of these defects. So in these particular things, we always counsel the couple not to go for abortion or termination. With this, I end my talk. Thank you so much. Thank you so much for your kind listening.
Thank you so much for that wonderful comprehensive presentation. So I'll give the room a chance, if you have any question, to ask in 5 minutes before you go to the next speaker. Anyone with a question? All right.
Okay. My question is, what are the medical interventions to enable the body to maintain its thermodynamics during surgery? Because at that time, the heart is usually stopped from pumping blood.
Yes.
Yes.
So the medical interventions during the cardiac surgery. So usually when we do cardiac surgery, we stop the heart, right? We take the circulation of the body on the bypass machine. So to stop the heart, we use cardioplegic drugs, which stops the heart. And During the surgery, of course, the heart doesn't work. The surgeon operates on that. And post-surgery, we reverse the changes and we pace the heart and start on certain inotropic drugs. In our center, we use dobutamine, adrenaline, and noradrenaline, of course, with the NTG as a backup to keep a good coronary blood flow. So these drugs do help in, reviving the heart back and giving the heart a normal function. And sometimes, if needed, we sometimes post-surgery, we pace the heart with temporary pacemakers, epicardial temporary pacemakers. We put the pacing leads and pace the heart.
All right, I'm seeing we have another question on the floor. So it means your talk was very interesting, eh?
Yeah, thank you.
Okay, I'm David Mogaka.
Yes.
I was asking, we are using the medical devices to end these structural heart diseases, and maybe from literature, some medical devices have been implicated in cardiology or cardiac infections, like endocarditis.
Yes.
Is there any follow-up for the patients, since it's done in, maybe you've said, in little children? Is there any follow-up or something done for the cardiac infections?
That's a very good question. And yes, of course. See, any foreign body we are putting inside the heart. So the blood is going to flow through the heart to the organs, right? So there is always a propensity to cause infection, for the infection of that particular foreign body inside your heart. So the precautions which we usually take before deployment of these devices. One is, of course, a completely sterile medium. We do a good scrub. We prepare the baby well before the procedure. A pre-procedure antibiotic is given, and we give the post-procedure antibiotic also for minimum 5 days. So talking about the body, the device is going to stay inside, right? So it is going to stay for the rest of the life. So what are the chances in the rest of the life whether this device can get infected? I suppose that was your question. So the thing is, what happens when we put these devices inside the heart or in the vessels? What happens that with time, these devices endothelizes. There is a formation of endothelium over these devices. So these don't remain raw inside the heart. Slowly the cells start growing over the device. They form a layer over the device, which is a protective layer to prevent these devices from getting infected. These devices are basically made of alloy, that is nickel and titanium, nitinol, and along with that there is Dacron fibers inside the device, which helps in the growth of the epithelium over the device. So that's the technology, and that's how the natural history of the post-device deployment goes. Chances of infections are bare minimum once they endothelize. Approximately time for the endothelization starts right from the time you have deployed the device, and the process completes by around 3 months. So we do advise the parents or the guardians of the baby to definitely protect the child from the infection, or any fever or something happening, report to the hospital as early as possible. If there is anything like that, after 3 months, the chances of infection is bare minimum.
All right. So we have another question here.
Hello, my name is Derek.
Hello, Derek.
My question come here where there is neonatal syndrome. So exposure, what 3 types of exposure that attack the neuro?
Sorry, I didn't get you. Neuro?
I said the neonatal syndrome.
Neonate, okay. Yeah.
Yeah, syndrome.
Neonatal syndromes, yeah.
Yeah, there's a cause.
Cause?
Yeah.
Yes.
So I need to know.
Yeah, of course.
About it.
Okay. So if you talk about neonatal syndrome, yes, of course, syndromic babies always have propensity to have these kind of structural defects in the heart, or congenital heart defects, what we call. And if I talk about congenital defects. So if you talk about the congenital defect can be of any part of the body, right from the head till toe. The baby can have any abnormal organ or any abnormal limb or any abnormal structure. So among them, the most common are the heart defects. Of all the congenital defects, heart is the most common organ which has got the maximum kind of defects. from all the congenital defects. So definitely the syndromic babies always have a propensity, and they got a high risk of having these defects. And you talk about Down syndrome, Edwards syndrome, Patau syndrome. There are so many in the list. And of course, with particular kind of a syndrome, you have got an associated congenital heart defect, which you should keep in mind when you are evaluating a child. Just a simple example, like a Down syndrome baby, you will always think of an AV canal kind of a defect, complete atrioventricular canal defect kind of a defect, where there will be 2 holes in the heart and there will be a common valve which we have to reconstruct. So yes, of course, with the syndromic babies, the chances of having these kind of defects is very high.
All right, I'm seeing still more questions from the floor.
Thank you, Dr. My name is Diane Jeff.
Hello.
Under echocardiography, I want to know the nursing responsibilities under that echocardiography responsibilities when you consider conductive gel, when conductive gel is applied.
Okay, the nursing responsibilities you want to know in the echocardiography procedure, right? That's your question? Yeah, okay, fine. So, yes, of course, see, echocardiography is also a kind of a procedure which is, which for any layman entering into an echo lab and going to lie down on the bed for a particular procedure. So, it's like an alien space for a layman who's coming for that particular test. We as medicos know very well that echocardiography is a non-invasive procedure where we are just going to use the jellies and an echo machine to detect kind of a heart abnormality. So as a nurse, the responsibility which comes is right from the time the patient enters your echo lab. The nurse should brief the patient about the procedure. The nurse should help the patient in getting ready for the echocardiography by wearing a more comfortable dress which is available in the echo labs, which can easily expose the upper sternum to make a good window. And of course, the nurse should guide the patient in the positioning on the bed, how the patient should lie down before we go for the procedure. And of course, a little briefing about non-invasiveness of this procedure or a painless procedure is very important, because the patient will always get apprehensive what they are going to do with me. So that is very important. And if we talk about the echocardiography in small babies, neonates or infants or small babies, another important point which nurses should take care is keep the jelly warm. The jelly which we use to put on the probe, keep the jelly warm. And there are warmers available nowadays with the advanced echo machines where you can just put the jelly, it is electronically heated, and that jelly remains almost like a body temperature, and it doesn't give that cold feeling to a baby. And once the baby will have that cold feeling, suddenly he'll become cranky. Your procedure of echocardiography is going to become very difficult once the baby will start crying. You have to be a big expert then to detect that particular kind of a complex heart disease. But a calm baby and silent baby can always give you good echo pictures. You can always play music, you can always play videos to distract the baby from the procedure, or you can even show the echo to the baby also. So seeing the color Doppler on the echocardiography machine, the blue and the red color, the babies feel it's a cartoon. You can keep on conversing with the baby and the parents. So that makes environment a little more friendly for the patients, and you can perform a wonderful echocardiography to give a good diagnosis.
And what about the precautions needed for echo test under the same echocardiography?
Okay, so basically transthoracic echocardiography as such doesn't require much of precautions. It is simple, you are doing outside the chest. But yes, of course, the transesophageal echocardiography, what we do, that particular echocardiography does require an fasting patient. The patient should not have meal at least 4 to 5 hours before procedure, because we are going to put a transesophageal probe which is going to go through the esophagus and give us a cardiac image. Right? So transesophageal echocardiography, we have to keep the patient empty stomach for 4 to 5 hours. We have to pre-evaluate the patient for any loose dentures. If there is any loose teeth, that can break and go inside. And again, we have to spray the local anesthesia in the mouth so that he can gulp and doesn't get much pain during the procedure. So these are the things we have to keep in mind while doing transesophageal echocardiography. And precaution related to fetal echocardiography. For fetal echocardiography, you see the fetus is inside the womb of the mother. The baby is going to move inside, right? So you're going to lose your cardiac field. So the best way to keep the baby calm is to fill the tummy of the baby. What I mean to say, the glycemic indexes should be good in the baby. The mother should have some good amount of food before coming for a fetal echocardiography. So good amount of the food, when mother will have a good meal, the glucose level in the baby will be high, the baby will be calm and will not be moving much. That helps you in holding the heart in one position and easily do your fetal echocardiography. Yes, yes. No, before test, of course. Before test. You want the baby to be calm before test, not after test. It's okay, let him move after test.
All right, because of time, we are going to limit questions. My final question is that I know you have diverged so much on the complex cases. For me, I'm now being practical in our scenario here in Kenya. In our public health case, both private and public.
Yeah.
At the publics, you have the central and the devolved healthcare system. The challenge is that most of these things you're talking about are not easily available in most areas of the country. On our side, I know you have these challenges, but now from your perspective, from India perspective, what is the screening method? Like when you're talking about the neonatal screening or the fetal screening, do you screen every pregnant woman or only those who are interested who come to your facility?
Yes, of course. I mean, there are certain indications for fetal echocardiography. If I talk about the list of indications, so one is definitely a diabetic mother, a mother with the thyroid issues, a mother on some sort of medical management, maybe a chemotherapy or any drugs which you feel can affect the baby's structure formation, any previous history of having a baby with congenital heart defect, and a mother with first trimester, bad first trimester history, first 12 weeks when the organogenesis happens. So if at that particular time mother had high-grade fever or had admissions for particular infection, that becomes an indication for fetal echocardiography, of course. And yes, primarily the radiologist do that anomaly scan. So if the radiologist is quite confident that he was able to see the heart properly in all particular chambers or in the moving baby, and he's confident that the chances of structural heart defect is low, then of course, they usually rule out the heart defects. But yes, of course, if they are not confident or they feel that the baby heart image which they made, they are not confident about that, then definitely sending to a pediatric cardiologist is a wise decision. Because sometimes the babies are flexed on themselves, you are not able to see the arch. Sometimes the babies are in some transverse lie position where forming a 4-chamber view is very difficult. So coming to a pediatric cardiologist, the pediatric cardiologist's eyes knows each and every defect because we have a knowledge about that particular defect. So we can definitely screen the heart in detail and look at every particular point which we know very well might be missed during a routine anomaly scan by a radiologist, especially the arch. Arch is missed a lot, or TAPVCs are missed a lot, total anomalous pulmonary venous connections. These are certain defects which are sometimes missed easily. Actually, on the structure of the heart is very important. These are the certain indications you can of course follow. But along with that, yes, of course, the technicalities. If technically there was a challenge in seeing the heart of the baby, then a pediatric cardiologist should always be, brought into the picture to give a better diagnosis. Yeah.
Thank you so much. I think that's well explained. For us, as people who are here in healthcare, now for the baby has been born, failure to thrive, we are seeing the baby is not gaining weight as expected. So that's an early indication for warning. If you're able, you can pursue along those lines. The challenge with us as a country is that we don't have so many pediatric cardiologists. Yeah. Because even sometimes where I practice at Kenyatta National Hospital, you send them for echo. Yes. Even a child who is 10 years or 12 years, they'll tell you go and look for a pediatric cardiologist. And
see, I'll tell you one
of the challenges we do have here.
Yeah. So a very important point here is, see, echocardiography, angiography, complex procedures are totally different. Still, the basic is the clinical examination. I still believe in that. Even when I do an echocardiography, I have a doubt that maybe this thing is not very clear to me, or what's the severity of this thing. I go back and do the clinical examination of my child. I see the murmur, I hear the sounds, I see from where the murmur is starting, where it is ending. It is pansystolic, early systolic, early diastolic. I go with all those things. So nothing can replace the clinical tool. So advance is whatever it is. So detecting a child with the clinical examination is an art, and the more you stay away from the technology, the more you will go into that particular thing. And I always emphasize certain signs which you should see in a newborn baby or a grown-up baby is definitely, of course, breathing difficulties, recurrent chest infections, failure to thrive, cyanosis, bluish discoloration of skin. A little grown-up child will complain of easy fatigability, exertional fatigability. He'll not be able to perform as per his peer group. So in the sports or in the school activities, or a chest pain, headache, leg pain. So definitely these are the kids who deserve an elective echocardiography. So if you feel clinically the child is stable, or there is no emergency, you can go for elective echocardiography. But a huffing, puffing child or a deeply cyanosed child does require an early echocardiography, because echocardiography is a simple non-invasive tool. Just by screening the heart, you can detect majorly what anomaly this child will be having.
All right, thank you so much. We can now give him a happy clap.
Thank you. Thank you so much. Thank you so much.
Thank you so much, Mr. Deepak, for this wonderful presentation. You can now have your seat. We are going to take a break before we resume again with Dr. Mahesh talk. Meanwhile, we are going to have a small presentation by Mr. Badruddin. He's from United States of America. He's an expert in healthcare technology. So he's going to give us a brief talk on optimizing healthcare with advanced technology. Then we shall resume our cardiology series. Thank you. Welcome.
Yeah, I have few slides. Can you present the slides, please? Hello, everyone. My name is Badruddin Peter. I'm CEO at CallK24. I'm coming from US. I'm a graduate from MIT, but I have been focusing on a lot of advanced technologies in the last 25 years. We have done phenomenal research into various technologies, but again, the objective of today's session is to bring in few of the advanced technologies into the healthcare area, and I'm going to present them, like what kind of solutions we are bringing in here. Let's wait, yeah. All right, so CallK24, I will just walk you through the agenda, a very high level of the topics. We are going to talk about CallK24, the kind of study and research we have done, and then what are the solutions, possible solutions we are bringing onto the table. You might have heard about these solutions at several instances, but again, we have done a phenomenal work in US, Saudi, India, and now we are trying to get those technologies into Kenya. Apart from that, what are the benefits and improvements with these technologies to you? And where are we located? What is our global presence? I'm going to talk about that. So CallK24 is a US-based company. It started it is a very young company, but it has been started like 3 years back. But we have been doing a lot of work with a few clinical partners since 2016 to study the patient engagement and also the patient journey when they onboard onto the platform, how they can be treated, and how user-friendly the platform can be, and the treatments and services can be, and what are the advanced technologies that we can bring in to streamline this process. Well, in our study and research, there are 3 key factors that we have found. where the medical has become a huge, our healthcare has become a huge cost for the patients worldwide. And it has grown so much that patients are not able to afford it. Then there is a time constraint where the users are trying to access the healthcare, but it is not coming to the patients in the timely manner. It is coming a little delayed. For example, in US alone, for any kind of dermatology appointments or any kind of cardiac appointments, you have to wait at least 6 to 8 months before you even get treated or diagnosed. Then the specialist. There are very, very few specialists in specific areas. As doctor was mentioning, it is very hard to get access to these specialists worldwide, and we are trying to bring in or reduce the time of accessing those specialists worldwide. And these are the key challenges that we have found. There are several statistics we have found in these areas, but again, I'm not going to walk you through all those because of the time constraint. Now, what are the key solutions we are planning to bring in to mitigate all the challenges we have seen? There is a telehealth platform that we have brought in, and then there is a remote patient monitoring and also a medical tourism. Medical tourism in the sense not to take away the kind of people from here and provide the health services outside, but getting the outside health specialist here and providing more and more advanced platform for you and specialist for you. And what are the benefits that you can achieve by bringing this platform into Kenya? And by bringing our solutions here, you can reduce the cost phenomenally, like more than 40% of the cost can be reduced on whatever you are achieving today. And then the time, you don't have to wait like 6 months or 8 months to access to the specialist. And the specialists themselves can travel down here based on the need, because we have a presence worldwide in US, Saudi, and India. We can bring in all those kind of specialists here at your doorstep. Now let's talk a little bit more on the kind of features we are bringing on the telehealth, remote patient monitoring, and medical tourism. I will take you to those slides. Before I go there, what are the kind of devices or advancements we are bringing in? So from the, for any kind of acute condition that need to be diagnosed or identified in a patient, there are few key vitals that are required. And most of the doctors or specialists, they allow the patients to come in, get these vitals done at the hospitals. But what we are trying to do is, because of the pandemic and everything, it is becoming very hard for the patients to walk into the door. So we are bringing in these tele devices into your hand so that you can stay at home and still be able to share all these vitals to the doctors. Now, apart from these vitals, there are few key areas that we have worked on, bringing the diabetic care, so that you can stay at home, like not with a glucometer, but we have partnered with Abbott and Dexcom to bring in their technology into our platform so that we can take it to rural world, I mean, like wherever the healthcare is required. And in the blood sugar, ophthalmology, dialysis, I mean, like telesurgery, all this kind of research is happening in the back end, but as of now, our platform is ready with the vital monitoring. So telehealth plus, there are few key features that you can access. The biggest challenge any patient is finding is to search for a provider, search for a doctor. And you can use our app, download our app, and search for the doctors anywhere in Kenya, anywhere in Saudi or India or US, based on the region. So we are bringing all those specialists here so that you can have access to the providers. Now, apart from this, you can schedule the appointment through your phone and have a teleconsultation with them even prior visiting them in person for any kind of treatment or procedure that need to be done. And this app is provided with all kind of advancements, like there is a AI engine sitting in the back end, which can monitor, which can send you the alerts, and which can communicate with you. It will also allow you to communicate with your doctor through the chat messenger or through the phone call or through even the televideo visits. And this platform is enabled with several kind of reports which you can be able to access. In US, we are integrated, we are working with major hospitals, we are integrated with several kind of EMR, like health management systems, and we also started working in Saudi with the Ministry of Health We have recently entered into a contract with them, and we implemented our solution to South Al Babtain Cardiac Center, and now we are going to King Faisal Hospital. We are expanding our services into Dubai, and we also partnered with several hospitals in India, in southern part of India, and we are going in northern part of India as well. Now, why we are doing this? We are bringing all those specialists to you guys and the technologies to you. And the objective of our platform is seamless integration of your data. Because if you go from one clinic to another clinic, there is a major issue of accessing your health records because they stay in one hospital. And the other hospital has to go through again, checking you, getting all those historical data by making you go through the test. Now, because of which the cost will increase for you. Now, our platform can provide all the historical records in a single platform, even though if you have taken a treatment in US, it doesn't matter, Saudi, it doesn't matter, even in India, it doesn't matter. It is in your hand, and you can always share with your doctor, and doctor has access to your records. Okay, this is just a pictorial representation of what I was saying. There is a seamless integration between our platform and various other platforms worldwide which can exchange the data. We are not only focusing on the medical, we are also on the dental. So all your records are in a single central location. Remote patient monitoring. Now, RPM, I know you might have heard about RPM. It is gaining a lot of traction worldwide. The key objective of RPM is to reduce the readmissions into the hospital. Any post-surgery patient, if they have to, without getting them readmitted into the hospital, they can be still monitored from home. Doctor doesn't have to come to you. Because of our telekits which we give to the patients, the doctor will be able to see all your vitals on a daily basis. And our team is sitting along with you guys to make sure those vitals are recorded on a daily basis. So these are some of the features. But again, our platform is like you collect the data using the tele devices at home, and you don't have to do anything on our app. Our app automatically synchronizes the data into the application, which is immediately available to the doctors. Our servers are working in the back end to communicate data back and forth. And this is one of the workflow we have implemented at Saudi, where you can see the patient is registered, the initial readings are taken, then in the patient monitoring, the middle section, the patient will be monitored for 10 to 30 days continuously using the devices we are providing them, and this data is available to the doctor to provide any kind of prescriptions. This is one of the layout on the RPM side, how the telehealth and RPM both are connected, how the data is synchronized with our platform, and it is exchanged worldwide. These are a few of the devices we have partnered with. We have already integrated them, and the two new devices that we are integrating right now are Holter monitor and then ventilators. With that, we are going to at least complete a level of tele devices integration, and then we will expand our services into the ophthalmology side. And these are the few cardiac or at least RPM kits that we provide to our patients. Like there is a universal kit, cardiac kit, diabetic kit, viral kit. Again, I'm not here to do a sales pitch. What I'm trying to convey to you is what are the kind of advancements we are doing worldwide, and what is that we can bring in to Kenya so that we can make the patient life and patient journey more helpful, more meaningful. Now, the last part I would like to discuss is the medical tourism. Again, this word, many of you might not like it, but this is the wellness program. What we are trying to do is, because we have the global presence in US, Saudi, and India, access to a lot of specialists over there. Right now, our platform has more than 20,000 patients onboarded in US alone. And in Saudi, we are targeting 60,000 patients to be onboarded by end of next year. Now, with that kind of patient data, with that kind of specialist from these two different worlds, and India coming onto the plate with many hospitals, all these specialists are available at your doorstep. Now, you would like to talk to them, you would like to access them, you would like to ask them to come here, it can be done through our medical tourism services. And this is our global presence. Kenya, we are starting here. This, at least, expo has helped us to get closer to Kenya, and we are going to start our services from next week. Thank you, and we have a booth at G88. Please come and visit so that we can walk you through our applications and devices. Thank you so much.
Thank you so much, Mr. Badruddin. Anyone, before you leave?
I would like to thank my team who came all the way from India and US. I have Mr. Dastigiri. Dastigiri, can you raise? He is a Dr. Dastigiri, and he is our Vice President of Sales from India, who is helping us. We have Mr. Saifuddin. Saifuddin is the Director of Operations who came from India. And I also have one of my friend who traveled from US again. He is on a different purpose, but he took time to come over here, Mr. Joe. Thank you so much for coming here and joining us. Yeah. Thank you, guys.
Thank you so much. Before Mr. Badruddin leaves the floor, is there anyone among the audience who have a question for him? Anyone? All right.
What is the question?
What is the difference between telemedicine and
Telemedicine and? Telecare?
in other words, how is it?
Telecare क्या है? Okay, so I'm sorry, I didn't understand the telecare word. So the telemedicine, we are trying to bring in all these tele devices to your home so that you don't have to go to the doctor. You can still share your personal vital data sitting at home. For example, there are old age homes where there are many patients who are required attention at home, and there is a nurse staff who travels to home on a weekly basis. They kind of do the treatment to the patients, collect all the vitals, and send it back to the doctors. Now, they don't have to do that. We can minimize that transportation or logistics, and the device kit is given to you. Tele-device kit is given to you so that you can take those vitals at home itself and share it with the doctor. Did I answer your question? So telehealth is nothing but the advancement on the healthcare side, where you are trying, where you are trying to advance, where you are trying to better your health through the tele devices. Now, telemedicine is similar. I mean, like it is just a different word given, but it focuses on the medical side, not on the dental side. Because on the dental side, we still don't have tele devices that can do the healthcare facilities for you.
All right, so what you're going to do, you're going to take a break. Thank you so much, Mr. Badruddin. They have a stand outside here, so if you need more information, kindly look for them when you're going for the tea break before we resume. So we are going to take a break for 20 minutes. Hopefully resume by noon, before noon, few minutes to noon, so that we continue. Thank you so much.
cables. We value the freedom to explore new ideas and seek to differentiate ourselves from the regulars in the minds of customers. We choose and manufacture products based on the law of value. Your true value is determined by how much more you give in value than you take in payment. Biometric Cables, or BMC, was founded by Arun Kumar Chidambaram.
Biometric Cables started its operation in the year 2005 with 4 personnel and single product line. Today as we speak, we have around 3,500 plus products and expertise with 10 different value chains. We have over 5,000 plus customers.
Pulse oximeter sensors, NIBP cuffs, contouring accessories, and later breathing circuits. By 2011, by staying true to our values, we were the first company to manufacture ultrasound transducers in India. We were able to realize the product at 1/3 the cost of the OEMs and manufacture the product rivaling the quality of their Western counterparts. Our aim from the start has always been to follow international best practices for manufacturing medical devices.
From day one, I have been given very challenging and important projects to work on, like EMI EMC testing of electrosurgical products, regulatory complaints, EHS activities, and many more.
BMC acquired its ISO 13485 certification in 2007 and has since been continuously improving upon its quality management system. And today, we have CE certification for 4 of our product lines, having been accepted as trusted supplier for ultrasound and breathing circuits with hospitals and OEMs. By 2012, BMC had moved into factory cum office in a premier industrial area in the heart of Chennai to meet the demands.
We at Biometric Cables would like to go deep rather than going wide. We would like to be identified as experts in medical wiring harness industry.
Exploring further, by 2016, we were the first company in Asia to manufacture galvanic oxygen sensors and flow sensors for ventilators, and are one of the very few companies in the world that have the capability of manufacturing these O2 sensors.
With my previous experience in product design, I always had a dream of designing Intuitive products. The product realization process in BMC has challenged me to develop high-value products for the healthcare sector.
With the COVID-19 pandemic beginning in 2019, then Government of India, as were the rest of the world governments, was looking to cure 60,000 ventilators. It called upon Bharat Electronics, an Indian defense company, to produce 30,000 units. Oxygen sensors and flow sensors are crucial components in ventilators, and BMC was the only company in Asia capable of producing them. In collaboration with Bharat Electronics, BMC ramped up its production from 250 units produced per month to 15,000 units to meet the requirements within the deadline. We were happy to be able to assist during times of emergency, and it filled our hearts with pride knowing that our company rose to the challenge of saving precious human lives. We at BMC believe growing our people along with the requirements of company and market.
வேலை செய்யும் தொழிலாளர்களின் திறமையை மேம்படுத்துவதிலும் புதிய தொழில்நுட்பங்களை கற்றுக் கொடுத்து தொழிலாளர்கள் அடுத்த கட்டம் செல்வதற்கு உறுதுணையாக ஊக்கப்படுத்துகிறார்கள். இதனால் எங்கள் திறமையை வளர்த்துக் கொள்வதும் மேலும் புது திறமைகளை கையாள்வதற்கும் இங்கு உறுதுணையாக இருக்கிறார்கள்.
Today we employ 100 personnel with more than 60% of the staff having been with us for 6 years and above.
ஆரம்பத்தில் வந்து டீம் மெம்பராக ப்ரொடக்ஷனில் வந்து ஜாயின் பண்ணி ஒர்க்கை ஸ்டார்ட் பண்ணேன். இப்போ வந்து ஃபைனல் குவாலிட்டி கண்ட்ரோல் வரைக்கும் வந்து வந்திருக்கேன். நல்லா ஒர்க் பண்ணுறாங்கன்னா அவங்களுக்கான டேலண்ட்டை வந்து கண்டிப்பாக வந்து இம்ப்ரூவ் பண்ணி அவங்களோட அடுத்த ஸ்டெப்ஸுக்கு போகிற அளவுக்கு வந்து ஹெல்ப்ஃபுல்லாக வந்து இருப்பாங்க மேனேஜ்மெண்ட்டு.
We have gained the trust of over 5,000 plus customers, all attributed to our core values of delivering derived product value, service solutions, and continuous improvements in our products.
Biometric Cables sincerely believes we have to grow our people to meet the demands of the customer and the company.
We intend to stay true to our mission statement of sharing a common national vision of Make in India products for global markets. Biometric Cables, or BMC, a global competitor with humble origins, an Indian business story. At Biometric Cables, we value the freedom to explore new ideas and seek to differentiate ourselves from the regulars in the minds of customers. We choose and manufacture products based on the law of value. Your true value is determined by how much more you give in value than you take in payment. Biometric Cables, or BMC, was founded by Arun Kumar Chidambaram.
Biometric Cables started its operation in the year 2005 with 4 personals and single product line. Today as we speak, we have around 3,500 plus products and expertise with 10 different value chains. We have over 5,000 plus customers.
We manufactured ECG cables, pulse oximeter sensors, NIBP cuffs, cautery accessories, and later breathing circuits. By 2011, by staying true to our values, we were the first company to manufacture ultrasound transducers in India. We were able to realize the product at 1/3 the cost of the OEMs and manufacture the product rivaling the quality of their Western counterparts. Our aim from the start has always been to follow international best practices for manufacturing medical devices.
From day one, I have been given very challenging and important projects to work on, like EMI EMC testing of electrosurgical products, regulatory complaints, EHS activities, and many more.
BMC acquired its ISO 13485 certification in 2007 and has since been continuously improving upon its quality management system. And today, we have CE certification for 4 of our product lines, having been accepted as trusted supplier for ultrasound and breathing circuits with hospitals and OEMs. By 2012, BMC had moved into factory cum office in a premier industrial area in the heart of Chennai to meet the demands.
We at Biometric Cables would like to go deep rather than going wide. We would like to be identified as experts in medical wiring harness industry.
Exploring further, by 2016, we were the first company in Asia to manufacture galvanic oxygen sensors and flow sensors for ventilators, and are one of the very few companies in the world that have the capability of manufacturing these O2 sensors.
With my previous experience in product design, I always had a dream of designing intuitive products. The product realization process in BMC has challenged me to develop high-value products for the healthcare sector.
With the COVID-19 pandemic beginning in 2019, then Government of India, as were the rest of the world governments, was looking to procure 60,000 ventilators. It called upon Bharat Electronics, an Indian defense company, to produce 30,000 units. Oxygen sensors and flow sensors are crucial components in ventilators, and BMC was the only company in Asia capable of producing them. In collaboration with Bharat Electronics, BMC ramped up its production from 250 units produced per month to 15,000 units to meet the requirements within the deadline. We were happy to be able to assist during times of emergency, and it filled our hearts with pride knowing that our company rose to the challenge of saving precious human lives. We at BMC believe growing our people along with the requirements of company and market.
வேலை செய்யும் தொழிலாளர்களின் திறமையை மேம்படுத்துவதிலும் புதிய தொழில்நுட்பங்களை கற்றுக் கொடுத்து தொழிலாளர்கள் அடுத்த கட்டம் செல்வதற்கு உறுதுணையாக ஊக்கப்படுத்துகிறார்கள். இதனால் எங்கள் திறமையை வளர்த்துக் கொள்வதும் மேலும் புது திறமைகளை கையாள்வதற்கும் இங்கு உறுதுணையாக இருக்கிறார்கள்.
Today we employ 100 personnel with more than 60% of the staff having been with us for 6 years and above.
ஆரம்பத்தில் வந்து டீம் மெம்பராக ப்ரொடக்ஷனில் வந்து ஜாயின் பண்ணி ஒர்க்கை ஸ்டார்ட் பண்ணேன். இப்போ வந்து ஃபைனல் குவாலிட்டி கண்ட்ரோல் வரைக்கும் வந்து வந்திருக்கேன். நல்லா ஒர்க் பண்ணுறாங்கன்னா அவங்களுக்கான டேலண்ட்டை வந்து கண்டிப்பாக வந்து இம்ப்ரூவ் பண்ணி அவங்களோட அடுத்த ஸ்டெப்ஸுக்கு போகிற அளவுக்கு வந்து ஹெல்ப்ஃபுல்லாக வந்து இருப்பாங்க மேனேஜ்மெண்ட்டு.
We have gained the trust of over 5,000 plus customers, all attributed to our core values of delivering derived product value, service solutions and continuous improvements in our products.
Biometric Cables sincerely believes we have to grow our people to meet the demands of the customer and the company.
We intend to stay true to our mission statement of sharing a common national vision of Make in India products for global markets. Biometric Cables or BMC, a global competitor with humble origins, an Indian business story. At Biometric Cables, we value the freedom to explore new ideas and seek to differentiate ourselves from the regulars in the minds of customers. We choose and manufacture products based on the law of value. Your true value is determined by how much more you give in value than you take in payment. Biometric Cables or BMC was founded by Arun Kumar Chidambaram.
Biometric Cables started its operation in the year 2005 with 4 personnel and single product line. Today as we speak, we have around 3,500 plus products and expertise with 10 different value chains. We have over 5,000 plus customers.
We manufactured ECG cables, pulse oximeter sensors, NIBP cuffs, cautery accessories, and later breathing circuits. By 2011, by staying true to our values, we were the first company to manufacture ultrasound transducers in India. We were able to realize the product at 1/3 the cost of the OEMs and manufacture the product rivaling the quality of their Western counterparts. Our aim from the start has always been to follow international best practices for manufacturing medical devices.
From day one, I have been given very challenging and important projects to work on, like EMI EMC testing of electrosurgical products, regulatory complaints, EHS activities and many more.
BMC acquired its ISO 13485 certification in 2007 and has since been continuously improving upon its quality management system. And today, we have CE certification for 4 of our product lines, having been accepted as trusted supplier for ultrasound and breathing circuits with hospitals and OEMs. By 2012, BMC had moved into factory cum office in a premier industrial area in the heart of Chennai to meet the demands.
We at Biometric Cables would like to go deep rather than going wide. We would like to be identified as experts in medical wiring harness industry.
Exploring further, by 2016, we were the first company in Asia to manufacture galvanic oxygen sensors and flow sensors for ventilators and are one of the very few companies in the world that have the capability of manufacturing these O2 sensors.
With my previous experience in product design, I always had a dream of designing intuitive products. The product realization process in BMC has challenged me to develop high-value products for the healthcare sector.
With the COVID-19 pandemic beginning in 2019, then Government of India, as were the rest of the world governments, was looking to procure 60,000 ventilators. It called upon Bharat Electronics, an Indian defense company, to produce 30,000 units. Oxygen sensors and flow sensors are crucial components in ventilators, and BMC was the only company in Asia capable of producing them. In collaboration with Bharat Electronics, BMC ramped up its production from 250 units produced per month to 15,000 units to meet the requirements within the deadline. We were happy to be able to assist during times of emergency, and it filled our hearts with pride knowing that our company rose to the challenge of saving precious human lives. We at BMC believe growing our people along with the requirements of company and market.
வேலை செய்யும் தொழிலாளர்களின் திறமையை மேம்படுத்துவதிலும் புதிய தொழில்நுட்பங்களை கற்றுக் கொடுத்து தொழிலாளர்கள் அடுத்த கட்டம் செல்வதற்கு உறுதுணையாக ஊக்கப்படுத்துகிறார்கள். இதனால் எங்கள் திறமையை வளர்த்துக் கொள்வதும் மேலும் புது திறமைகளை கையாள்வதற்கும் இங்கு உறுதுணையாக இருக்கிறார்கள்.
Today we employ 100 personnel with more than 60% of the staff having been with us for 6 years and above.
ஆரம்பத்தில் வந்து டீம் மெம்பராக ப்ரொடக்ஷனில் வந்து ஜாயின் பண்ணி ஒர்க்கு ஸ்டார்ட் பண்ணேன். இப்போ வந்து ஃபைனல் குவாலிட்டி கண்ட்ரோல் வரைக்கும் வந்து வந்திருக்கேன். நல்லா ஒர்க் பண்ணுறாங்கன்னா அவங்களுக்கான டேலண்ட்டை வந்து கண்டிப்பாக வந்து இம்ப்ரூவ் பண்ணி அவங்களோட அடுத்த ஸ்டெப்ஸுக்கு போகிற அளவுக்கு வந்து ஹெல்ப்ஃபுல்லாக வந்து இருப்பாங்க மேனேஜ்மெண்ட்டு.
We have gained the trust of over 5,000 plus customers, all attributed to our core values of delivering derived product value, service solutions and continuous improvements in our products.
Biometric Cables sincerely believes we have to grow our people to meet the demands of the customer and the company.
We intend to stay true to our mission statement of sharing a common national vision of Make in India products for global markets. Biometric Cables or BMC, a global competitor with humble origins, an Indian business story.
Upfront and get the property. We felt that one of the biggest problems that doctors have is that they are uneducated in business. And I came across this when I went to my bank one day. And at that time, with that kind of salary, you don't see the bank manager. It's interesting that when I went to my KCB bank, the branch manager said he wanted to see me, and I was told by the teller, the bank manager, had said that next time you come. So I said, why would you want to see me? Because he says that you are active in KMA. So I thought that he was going to calling me because my bank was in the red, because it was always in the red anyway. But it was a surprise that he told me that, I wanted to see you to see if we can help you and your association. If you don't mind, I would like to have a chance to talk to your members about making money work for you instead of you working for money. Because I think that you people work too hard for the money, but the money doesn't work for you. And that became an interesting thing. It happened during one of the branch meetings where I had gone for the branch meeting, and I think it was a dinner. And during that dinner, where doctors come with their spouses, and sometimes even their children. So I was asked to make comments as president of the organization and say that we want to make it there. And I approached this idea that we would like, and we're working with private institutions to help doctors go on holiday. You know what the reaction was? All the spouses of doctors stood up and said, yes! That I've never been taken for a holiday. This guy just the only time that he takes me out that if they group one. Then we started learning that people filed for car insurance and life insurance. We could go as a group and get better rebates because they assume that the doctor has blood pressure checks regularly, so we should live long. I don't know if that's true, but we push that idea. So all of a sudden, there were economic opportunities appearing where as doctors, as professionals, we would use our professional standing to our economic advantage.
But in that period, something also happened in terms of welfare. We felt that as doctors, most of us who are employed in government were actually in Afia. But because of our numbers, we were always the minority. So I think some of your colleagues, the younger people, just said, we must start our circle. And I particularly remember Dr. Kilonzo and Dr. Kwara. And they just came to me and said, Chair, we are starting our circle. I said, fine, go ahead and start the circle. So then they actually started, mobilized, and the circle came into being. And now it is $1 billion.
One of the things that KMA HIV committee did was to partner with corporates and to make ARVs, antiretroviral drugs, available at very good prices. At that time, when a course for 1 month would even cost about 50,000 to 100,000 shillings, with partnering with corporate pharmaceuticals, they made this accessible, and the prices came down to less than 500 shillings. This was a great achievement. Of course, there was the issue of training, training doctors, training nurses, and training pharmacists.
I have a very strong feeling that is what actually brought me to government. Because after that, when we said it could be done, people could be treated, and we have put a system of treating. I was called by the head of the civil service then, with Dr. Muga, who was the director of medical services, and Mr. God, who was the PS. A month later, I was asked to be DMS.
The opportunities availed and doors opened by associating with KMA cannot be understated.
I decided to do pathology immediately after my internship, and I had to go and apply for scholarship from the ministry. And when I went, I was told, "You are crazy. I mean, you just finished internship, you have to do 2 years." And I told them, "Why do I need to do 2 years of cesarean sections and other things when I want to become a pathologist?" So somebody refused at the provincial level then. I was told, if you want to be assisted, you better go to see the DMS. So I mean, for most junior doctors, or anybody for that matter, DMS office is such a big office. How do you? But because I had been with KMA for 2 years by then, I had interacted with Professor Richard Muga in very many circles, because as a DMS he was a member of KMA. Then he says, "But is there anything you have done? Because the reason why you have to work for 2 years is because you build a CV, you know what you have done." I had done a lot for East Africa Medical Journal, even published some articles, again, because of my interactions with people like Professor Lore. So I had all my dossier there, and I gave it to him. And as I was walking away, he told me he'll call me later, but as I was walking away, he called me back, and he says, "Go and pack your things and start. We'll find a way."
I think KMA has gone through a lot. KMA is alive, it's vibrant, it brings us together. It gives me a reason to associate and network with my colleagues.
I do not think there's any other place that a young doctor can sit with an old senior doctor and discuss things as equals other than in KMA. Because you know, in the hospital environment, it is very heavily regimented. We practice medicine almost like the military. So that if I am a senior doctor in a certain area, then people must respect me, people must give way whenever I say something, people must consider it seriously. But when we sit as colleagues in KMA, we sit almost as equals, because we can listen to everyone. Every idea is welcome. And it is those ideas from the young doctors that have helped to transform this association to the vibrant, outgoing, and visible association that it is today.
I mean, this is an institution that has exemplary skills, number one, in-house. It has potential to grow this. I mean, within the region, we're leading. We're the strongest within the region. So aside from offering leadership in terms of that regionally, we stand to push, one, our agenda. It's actually our agenda in ensuring quality of health is delivered to the citizenry of Kenya, in ensuring that all Kenyans have an access to a skilled health worker. Number two, can be able to afford this skill, these services that they require anytime, rather timely.
KMA Center in Upper Hill, Nairobi is a state-of-the-art business center comprising office spaces, restaurants and apartments. It is the pride of KMA.
The vision of KMA Center was to be a self-sustaining project to provide continuous funding for the association so that the association can concentrate on its core business of providing health to the country and being a doctors' welfare association.
So the KMA Center was part of the team that started it from simple paper. I remember working, I mean, we had meetings for very many hours, discussing the plans, discussing the approach, the strategy to use to recruit people, to join the vehicle that was going to invest in it. And for us, the biggest achievement was actually putting up a 2 billion commercial structure in Upper Hill. And we had the President of the Republic of Kenya opening it. As a profession, doctors have been seen not to be entrepreneurial. So we took a big risk, and I think it just went to prove to the other associations that it's possible, that professionals can and should be involved in entrepreneurship and building this economy.
With the eyes of the world focused on access to universal healthcare, KMA is fully engaged in advocacy and policy development, laying the groundwork for the future of healthcare.
It's not doctors alone that can change the health system. It's impossible globally. It's not the nurses. Neither is it the pharmaceutical companies or the insurance companies. Healthcare is like an orchestra where you have everyone playing the instrument at the same time to produce music. Doctors are one piece of the health system. Professionals are one piece of the health system. And then there is the industry, there is the pharmaceutical sector, and there is the healthcare financing sector. All those subsectors put together produce the health sector in totality.
The entry of executive CEOs also starting to professionalize the activities of KMA. Without those changes, KMA would not be where it is.
Picking another SDG on gender equality, KMA is very particular about that. We've had the first president of Kenya Medical Association, a chairperson, been a woman. That tells you a lot. We've had the first CEO being a woman, the second person, telling you that there is room for us to also push towards their third rule as per the laws of this country.
In 61, 62, when I was in Mombasa, okay, I was with local authorities, but then other doctors says, oh, we are members of KMA, and so I joined KMA. But as a female doctor, when you go there, there were either you are alone, or there may be one or two ladies, and when you talk to your male counterparts, they would just say hello, hello, and there won't be any further talk, and you feel isolated. So one would avoid sort of going too much to those meetings, you see. There is a big change to the extent that this year, even your conference is dominated by female doctors in organization.
I'm really happy to see a lot more younger doctors who are not only becoming members, but also taking up leadership positions within KMA, because I think that to me symbolizes that KMA has many more years ahead of us, that KMA will outlast us.
As a young doctor, being a member of KMA, I've benefited quite a lot. Number one, it builds your professional capacity. You're able to interact with a lot of senior doctors who, number one, they mentor you. Number one, they grow your leadership skills. Usually, if I was not a member of KMA, currently where I serve, I am not a leader in my position at work, but where I serve as KMA, I have gained the leadership skills. I'm actually able to run an office, having been in the KMA Nairobi division.
Today, KMA carries out its activities in 17 divisions across the country and is engaged in advocacy and governance with county governments, nationally and internationally.
Now we are interacting even wider, and I think this more so in the last 2-3 years, we have engaged more within the Africa region. KMA championing for the formation of a Federation of East African Medical Association. The greatest link having been, I think, with Uganda. We attend each other's conferences, and we have football teams that play very serious games, and you know, there's always who's going to win this game. So that's the Matthew Lukwia Cup. And further than that, we've gone onto the world, the global front. So KMA is now on interacting greatly in the World Medical Association, again interacting with members from all over the world who are members within the association. And again, the common thread is that as medical associations, as physicians, our challenges are so similar. So when we listen to each other, interact with each other, we can build each other up.
Over the last 50 years, the Kenya Medical Association has played a crucial role in the transformation of the health sector, emerging as a leader in engaging medical practitioners and the voice for provision of the highest standards of healthcare in Kenya and beyond.
Good afternoon. I want to resume. So let's settle in. The audience kindly let's settle in so that you can start on time and finish a bit early for lunch break. So let's settle in so that we can start. For those who are outside, kindly join us in the room so that we can resume. So I'm going to invite another speaker. You can use this side. So I'm inviting Prof. Joy, who is a pediatric cardiologist. She's experienced cardiologist in the field of pediatrics. She's a member of faculty at the University of Nairobi. She also practices at Kenyatta National Hospitals. She graduated from International Heart University of Italy in 1995 with masters in cardiology, anesthesia, and cardiac surgery. So she's really experienced. She does a lot of clinical work here in Nairobi and also outside Nairobi in many areas, including Kisumu, my home regional county, where she comes monthly as well to run the same pediatric clinics. So she's going to give us a talk on the face of interventional cardiology in pediatric today. So I'm also going to invite Dr. Deepak Thakur to join on the stage, so that at the end of this discussion, we are going to have a panel talk after this presentation. Dr. Mahesh will join us later from the talk. Dr. Mahesh, you can also join us on the stage as we explore now the field of pediatric cardiothoracic surgeries. For the time being, it's still interventional cardiology series. So we are setting up, the IT team is setting for us the presentation so that we can start immediately without wasting more time. So welcome, Professor Joy.
Thank you. Thank you very much for that kind introduction. Being a grandmother, as I wait for the presentation to load, I can always tell you a few stories. And the story goes that in the early 70s, everybody was keen to develop cardiology, and it was an East African thing, Kenya, Uganda, and Tanzania. And I think the government put in some efforts a little, but our seniors decided to do a walk a funds walk at that time. The government couldn't put in much. So during that funds walk, they managed to raise enough money to buy an echo machine. Those days it was black and white. And it had, this one was better because now it had Doppler, we could see a lot more. And so that was one of the milestones after the walk. The money was enough also to buy a cath lab. That time it was just a monoplane. We would put the patients in, just like some of those. It was carved, so we would put the patient in, tie the patient, and if we want to, and we only had two views, the AP and the lateral. I was a student at that time, so I can remember those pictures. And we would manually move the patient to go to lateral, and we were told if we wanted in between, then we would have an LAO position in between and a full lateral. And so for adults it was difficult because they couldn't enter into this spot, so it was mainly just for pediatrics. And if you put, when the child was going to lateral, and those days we never used to do sedation, it was on local, and the child would scream, and so as a student I got worried, why are they screaming? So when the child was going to lateral, and then we would talk to the patient and get our pictures. Then there was an international conference here where it was a general conference. A team from Loma Linda then decided, because we said we had a cath lab, to come and see what is there. And they had come, actually, they had come to do an open heart procedure. They did 15 cases, and so the cardiologists were there, and they decided to move in and see what was in the cath lab, with some catheters also. And in that position, they dilated, they showed us how to do a pulmonary valvuloplasty. So that was our first case in the 70s. Then we slumped a bit. Then the World, it was called World Laboratory, they decided to come and invest. They bought now a better echo machine, and we had our cath lab, and we were getting smarter now, so we told the government to buy for us a machine, so we got a C-arm. So we had this cath lab, so this doctor, Professor Philip Bonhoeffer, who was our age mate and who is an innovator on his own, he decided that we'll do PDAs. So he came with coils and embolized a few cases, and that is, our eyes got open. And that is where we started. When he went, we continued with our pulmonary valvuloplasties also. It was easier to learn. The unfortunate thing is that we were not smart. We used to pick the very sick patients and do them, and that time we would stay longer in the cath lab. Then at one time, a case with moderate pulmonary stenosis came, and we put it in and were very fast, and our local ego improved. So as we improved our ego, we were able to do PDAs. The few coils that were there, we only had coils. The other devices were there. We also practiced a few ASDs, the Starflex. And so we were moving, the number of conditions were moving. Back in the wards, because I had to practice as a pediatrician, we had rooms that were dedicated to children for oxygen. So it was 3-level, every ward had a room for children on oxygen. And we discovered that most of them, the blue babies, just needed the pulmonary valve to be dilated. And since we knew how to dilate the pulmonary valve, we dilated the pulmonary valves, and the ward got better, and lo and behold, I was shifted to the university. I moved from Kenyatta now. I got a job just because of that. So I moved to the university. And from there, we were able to now move on. We've had a lot of collaborations. The collaborations from people who believe in us, and also from people who are explore, and a few visitors, and we have learned a lot from the visitors. We then established the Gertrude's Garden Children's Hospital after Kenyatta, worked there, put in the cardiac services there. It became famous. It was predominantly a children's hospital. We were just doing echocardiography and diagnostics. The board realized we are even doing adults, and they were very annoyed with us, and they chased us. So we moved to Mata. So Mata took us with an open arm, and that is where we have done most of the procedures now. So most of the pediatric procedure, I'm not talking about adults, most of the pediatric procedures then are done in two hospitals, the Kenyatta National Hospital and the Mata Hospital. The milestones are that other hospitals have also gained popularity. Counties have now put in cath labs. We have a cath lab in Mombasa. We have a cath lab in Eldoret. A cath lab is coming in Kisumu. We have cath labs in the various hospitals in Nairobi, a cath lab at Nairobi Hospital, cath lab at Aga Khan Hospital, cath lab at Mpisha Hospital, cath lab at Karen Hospital. The Mata Hospital has upgraded their cath lab, and so we have grown and we have moved. We started training. We haven't had a university-based training, but we have people who, if you want to come, we have to talk to the National Hospital. Whichever year you want, your county government also has to allow you, or if you are free. And then we tag around as the diseases are many, the workers are few, and usually within 6 months, I can see the trainee who started is already good. The rest now is history. So we have the training capabilities. What we need to do is to get to the international standards where the board also recognizes it, and we are working on that, and we believe that with all these other facilities in collaboration, we are capable of getting more people to train, and to train in pediatric cardiology, and to also do interventions, because the laborers, the work is there. The laborers are still few. So I think I thought I would present through my laptop. The data is high, so there's a lot of it. So I think they're still working on it. So those are basically the milestones that we had to achieve. So if we look at our work, we are now, anything in pulmonary stenosis we can do. And because there's now a lot of people have recognized this work, because we also never miss any conference to talk. If it is Kenya Pediatric, we are there making a lot of noise. If it is Kenya Cardiac Society, we are there trying to say that even as children, children make noise. So we are there, we make more noise. And so most of this, as the interest is there, the amount of referrals have improved. But the pattern of referrals still amazes us. When we come to pulmonary stenosis, we don't see that mild pulmonary stenosis. Maybe they're doing them somewhere. But we see very critical pulmonary stenosis, the blue babies. And that is what has been having us there. So I think come next time, we're going to show what is it on this critical pulmonary stenosis that we have. Thank you very much. The story ends, and I can start my presentation. Next slide. So this is the background, the historical background of what cardiac catheterizations, or what pediatric catheterizations will be. And initially, in the 1950s, it was just a question of trying to understand the physiology of congenital hearts, and that worked. The 60s and 70s, they used it to get the anatomical details, and they used it for, which one moves? So in the 50s and 60s, the learning was of how to understand that anatomy. In the 80s and 90s, advances came in. Echo, initially it was only cardiac catheterization. Echo came in, and echo changed the face of our practice. And now other things have come in, MRI, and today we now use the cardiac laboratory for treatment. And the treatment also involves palliation. These are our local milestones. Our first case of pulmonary valvuloplasty, as I said, was done by the visiting team from Loma Linda who had come to do open heart surgery. They did 5 open heart surgeries and did one pulmonary dilatation. And so our eyes opened. In 1993, we did some additional cases of pulmonary stenosis and we reported them at the East African Medical Journal. 1994, it's still there. In 1994, we did our first case of mitral stenosis. As you know, we have acquired conditions, severe rheumatic stenosis, and our series then were reported in the JICA. In 1996, in 1995, at the Mataf Hospital, we closed the first ASD, and this was in assistance with Professor Bonhoeffer, Philip. And in 1996, we embolized the first PDA, and then did a few more cases, and reported this in the KCS conference. And so you can see that we're moving with Kenyatta and Mata. In 1999, Dr. Robert Madenge did the first case of PCI, and the adult program picked. And in 2006, the first CRTP was done at the Karen Hospital. And in 2015, the first study was done at the Aga Khan Hospital. So these are some of the milestones that are coming. Some of these firsts are now ongoing, except for the TAVI, which has not gained as much, but it is there. These are the scope of the interventions that we do in the pediatrics. The ones that we frequently perform now in most of the hospitals is the pulmonary valvuloplasty. The other pediatric interventions is mitral valvuloplasty, and that we do very quickly nowadays. And I think within the region that we have the most of the data. The other data comes from Sudan and Egypt. We do atrial septostomies when you need to create an ASD. We also close PDAs and ASDs and VSDs and coarctation of the aorta. These are the ones we frequently perform. There are some we occasionally perform, like the arteriovenous malformations. The respiratory team is also giving us some work now, and stenting of the pulmonary arteries and coarctation. Those are done but frequently. Once in a while we get out of the heart, and so we've done a few subclavian artery stenosis and then stented them. What we have not yet done are the valve replacements, and I believe the people coming after us will do most of that. But our area, the region, or the third world region, has some unique experiences. When we get referrals, they are sick infants. We've now started getting the neonatal referrals, and we are glad. The older children, the adults, and the elderly. So as a pediatric cardiology, we still don't have that dedicated GUCH service for interventions. So we do all the range from the neonatal period to the adults, especially if it is congenital. We know that with more people joining us, with more people training, this will be specialized, and we'll have a few people who are very good at something, not the jack of all trades like us. We also have a variable disease burden program. We have mild lesions to critical stenotic lesions or to hypertensive shunts, and we have to face them irrespective of the age. We also have really late presentation. Late presentation, late diagnosis at a time when other systems now come in to help us. But once we have renal dysfunction, we are very, very careful, and occasionally we wash our hands. But if the surgeons have washed their hands, then we can't. So we have to explain to the parents the risk and also try our best. And we still don't have specialized dedicated units just for catheterization or a cardiac hospital. We just have a section within the hospital which allows you to do the work. And so a few cardiac units, the cardiac units are defined by the cath lab and an echo being done for you, and maybe a clinic being done. But what we appreciate with time is that most of the hospitals now appreciate that they really have to invest in cardiovascular services. That is something which initially was not. But now most of the hospitals, when they're coming up, do appreciate that there has to be some scanning that will help through as they do the cardiovascular services, because referring a patient for echo, it means your ambulance will be running all the time up and down the streets of Nairobi to get echocardiography. So if you can get it within your hospital, then that's one of the major advances. And again, we have to do some emergency interventions and some palliative interventions. And again, the emergency interventions is when a patient with pulmonary stenosis now presents in a critical stage and has to be closed, or some AV fistula causing severe heart failure and has to be closed. So those are the ones we have been doing. Those are curative. But we also do some palliative services, and the perforation of the pulmonary valve when you have a really pulmonary atresia with intact septum are a few of the procedures that we do. But among the emergency interventions which you have to be called whatever you are doing to come and do, is creating an ASD. And now we have put this one to be at the registrar's level. We still have our other trainees who are with us who also do these procedures. Balloon dilatation of the septum is done by the cardiologist, the interventional cardiologist in the lab. We do very few balloon blade septectomies. In fact, we had one which we were recycling, but I think that was the end of it. We have not done atrial stenting. We have probably just one as a demonstration. And then the PDS stenting, we have tried a few. And then RVOT dilatation for complex lesions that we have done on a regular basis to decongest our systems. So this one of the emergency procedures is the Rashkin's procedure, which is done in the NICU by the fellows. And classically in our setup, we do it for transposition of the great arteries. But a few patients with pulmonary atresia have been done. Mitral atresia, a few, but not as much. And this is the Rashkin's procedure. You just have a PFO and you push the catheter across the PFO to the left atrium, to the left atrium, and then when it is in the left atrial position, you then open up the balloon and pull it up, and it creates a hole, and the child saturates better. It's an emergency procedure which really saves your patient and reduces a mortality. And we also have done balloon dilatations, especially when they are referred to us at an older age. We use about 6 millimeter balloon. Occasionally we might go a little bit higher, but for the neonatal period, that's what we've done, and it has still improved the mixing in that situation. And this is blade atrial septotomy. This picture is borrowed from my teacher and a young colleague. He's a younger colleague than us, but he teaches us, Dr. Shiva Kumar from Madras. And he comes on a regular basis. We keep difficult cases and cases that we have failed because we are not champions. And then he goes through with us step by step, and we realize where we failed, and that way we have learned. So that slide is borrowed from him. The atrial septal stenting, we've only done one case with him, and that allowed us to refer the patient out for further treatment. It was a complex hypoplus, but we thought we would benefit, and the parents were keen to have the patient assisted. We have done PDS stentings about 2 or 3. The PDS stentings that have been done were done in collaboration, the pediatrics and the adult cardiologist. And my pediatric colleague, Dr. Gashara, had a patient And my adult colleague, Dr. Otieno Harun, knew how to stent, and together they stented their first case at the Nairobi hospital, and the patient survived to have further treatment later on. And thereafter, they stented 3 more using the stents that we use in the coronary. And 2 of these patients have lived long to have other treatments. So I think that collaboration has also helped, and we still collaborate with them in cases where we need their help, and pulmonary PDA stenting is one of them. PDA stenting in the setting of complex congenital heart diseases. I couldn't get this picture to play, but it is a case where we did with Professor Bonhoeffer in a case of pulmonary atresia, and we had to open the PDA, and abroad or in a cardiac center you'd use radiofrequency, and then you go and perforate the imperforate pulmonary valve, and then you open it up. So what we do since we don't have the radiofrequency ablation catheter, we take the stiff end, after doing angiograms, we take the stiff end of the normal standard catheter and try and perforate. And I think we've done 2 cases. One was demonstrated to us, and also together with the other doctors, the next time they came, we got them to do some of these cases. Gets your patient in a better state. So that is a stiff wire. The end of the stiff wire, this is a case whereby you have a right ventricle, a small right ventricle, and the pulmonary valve is supposed to be there. There is a PD on that side making the patient survive. So you take that wire and you try and get, that's where you want to perforate, and then you move, you immediately, since you are on the stiff end of the wire, you have to be very, very careful. But it's not for the faint-hearted. So we don't try it as much if we know we are not going to achieve. But this is a group of patients who, even if you wanted to get to a cardiac center, you would not. They are very fragile. So back to the things we know, the pulmonary valve stenosis can be classified as mild, moderate, or severe. So once the gradient is around 45, 50, we want to come in and sort out the patients if there is need. But in our setup, most of the ones we have been doing from moderate to severe, and then recently a group of patients just coming with critical pulmonary stenosis when the gradient is more than 100 and something. But we have managed to do them, and we have that data. So this picture just is meant to show how terrible the heart can be. Usually the left ventricle is the one which should be bigger than the right, but you can see the right ventricle has taken over most of it, and so this is very severe right ventricular hypertrophy, and we even have some effusion in this patient. So it's a very, very sick patient. The first patient we had historically was in the ward, so had liver derangements, the anesthetic refused, and we lost the patient in a few days. Then we learned our lessons, because the anesthetic has to review the patient in the ward. The next, in another 2-3 months, I don't know where they came from, the patient also came in with very, very critical pulmonary stenosis. We played bad girls, hid the liver function tests. The urea and electrolytes were acceptable, took the patient and dilated the patient, and and thereafter we were able to do critical pulmonary stenosis. And nowadays we do them on a routine basis. We have dedicated cardiac anesthetists, so nowadays we are fine. We are off the hook, and most of them we can do. So you can see they also come in the old age. Unfortunately, I couldn't remove the eyes of this patient, the privacy, because that's what I wanted to show. This is an old patient, real clubbed, real cyanosed, but has a treatable condition and very mobile pulmonary valve. She's still alive up to now, and we are grateful. What is our experience? I'll give you this data. It's an old data. The other ones are being adjusted, but within that period of time, we had about 110 patients with pulmonary stenosis, age ranging from 4 to 43 years, and 65, almost 60% of them were less than 5 years. So we went ahead and did pulmonary valvuloplasty, and of those, we failed in 5, and of those failures, one was a table death. We just crossed the wire and the patient went into Brady. And we tried to resuscitate and we didn't. And we had our table death and it was not interesting. Then we said, okay, that one died for us, we were scared. So the next patients we sent to the surgeons and they had more mortality than us in critical. So we said, no, I think this is in our field. And that is our experience at the moment with the cardiac anesthetists. Our critical pulmonary stenosis have walked home. So that's the experience that we had, and this is one of the patients who had critical pulmonary stenosis. And look at that right ventricle. Even if you put in something there, you are bound to have arrhythmias. You are bound to have desaturations. So we got, and you're using a coronary wire sometimes, and I don't know, they come out faster than you do any small mistake and it slips off and you start the thing again. We've used others, V18 and the rest of it. But now, when we know we are having a critical pulmonary stenosis, that is the only case we put. Whether there was a simple case we could finish with and go to the complex case, we don't. That is the only case we put for the day. If we finish early, so be it. If we finish late, at least the patient is sorted out. So I wonder what the other, so that's just the procedure of dilating the pulmonary valve. So this is an older patient with critical pulmonary stenosis who you can see that balloon is a little bit big, and that is what sometimes we manage to get. And again, that is just some of the steps in the dilatation. I don't know whether it plays, but if it doesn't, the catheter is put in the right ventricle. We use a smaller balloon initially to dilate and open the pulmonary valve, and then later on we use a bigger balloon for the dilatation. And I think that this was just meant to show some of those pictures. And these are some of the complications we do. Occasionally, I think we are in a hurry, but occasionally we just cannot get the vessels quite well. They are quite sick. You try and get the artery and the vein and all of them very faint. So this is a patient we created an AV fistula or AV malformation in the legs. Unfortunately, was referred to us from the neighboring country. Was very sick, was flown in. So we did it on the same day, and I think we had issues getting the line, and 6 months when they came for review, the leg was bigger. And that was the first complication. We quite did recognize it as much, but after investigations, we realized we created a communication. So we called the surgeons in, and they closed the fistula for us, and the young man is quite fine. And for that, I got a few kangas and laces from Tanzania, and was very happy. So that's some of the complications. Let me quickly move to coarctation of the aorta since my time is running out. These are also some of the lesions that we have done, discrete, especially in the neonatal period, and also you can have a long segment, so it's a discrete segment and a long segment. And basically it can be part of a complex congenital heart lesion or as an isolated lesion. When it is part of the complex heart lesion, maybe a VSD or maybe something, we sometimes have to go in and increase the cardiac output by dilating this valve. So that's a patient with tight coarctation. neonatal presentation, pretty common, probably one of the 5th common complications that will make us go to the neonatal unit. Easily missed because sometimes it resembles neonatal sepsis, but occasionally we don't examine the pulses in these small babies. I think nowadays that there's emergency triaging and everything. We probably examine just the radial and you get it bounding, so you are happy, but the lower limb has nothing. And so for you to also pick it on echo, you need a high index of suspicion. But I think this is just a picture which were meant to show the serial dilatations. If they play, it's okay. If they don't play, these were just the steps that we take. Let me see if they, okay. Oh, okay. So you do this picture and you see it is a blind end. Then you pass a small wire by, and that's what we do. And then you dilate, because these are neonates. Occasionally the going through the neck is difficult, so we really struggle to get through the legs, and that is our final results. And quite happy. We probably follow the patient up and see what we do next, but that's what we've done in series. And in the older children, if coarctation comes as an isolated case, we prefer to send it to the surgeons. The teaching is changing a little bit, but in the recoarctation, we have done the balloons and dilated and then stented a few. These cases are a few. And we're happy to say that one of the patients that I saw him at 8 years, and he was going to school with my son. Then those days, we said the parents sent them to South Africa, and they had surgery done, but he had a recoarctation, and we then had to dilate, but because it was very close to the subclavian, we couldn't stent it much. But the amazing thing that throughout the journey that we walked with this young man, he was with us, and now he is a doctor. He's practicing in Meru, and he is a good friend and has formed the basis of some of our referrals and improvement of cardiovascular services. And I know he's going to be a cardiologist. He's walked that line, and that's where he wants, and we're quite happy for him. But that is the older child. And I think these are just some of those pictures. Let me see which one we're allowed to do. But you do an angio. So this is aortic stenosis. This we have done a number of them. We have done in the older children, we have just done this is called retrograde. We have come from the descending aorta and then approached it through the dilators. This is when we didn't have very severe stenosis and then dilated it. When we have severe stenosis, because we have the common practice for transeptal puncture in the mitral stenosis, we have used this in a few of the patients to do a transeptal puncture up the catheter, up the descending aorta, and then we have done some of the aortic dilatations. I don't know whether I have that data. And then, of course, the shunts, the ASD and the PDA and the VSDs, these are some of the things we've done. Let me see if it plays. Okay. So that's we put the Mullins in the left pulmonary, close to the left after pulmonary veins. I've foreshortened this. And then that is the ASD device. We do, that's the Minnesota movement. And then I think, let me see what, so that's just before we let go. And that is after we have let go. So again, you must make sure that when you pull it, it doesn't come back to the right atrium. So it stays in between and those also we have done. PDAs, we have smaller PDAs which we've done with coils. and also larger PDA. So this is a PDA that's, we are crossing it after we had done the angios, and then we put in the coil and then check with the photos later on. Some of the complications that we've had with PDAs is occasionally you think you have done your job, and when you finish, lo and behold, you've blocked the descending thoracic aorta. And so I think these are some of the complications. The first one that we did, we were so shocked, and so we called in the surgeon very quickly, and he went in the same day, removed the device, closed the PDA, and enlarged the aorta a bit. And the mistake we realized is that the aorta was relatively small, and we didn't assess that earlier. So some of the mistakes are there. The other complications we do have is for the device embolization, especially for the PDAs. So this is a patient who we were going to put the PDA, and of course you see it's just gone down the descending thoracic aorta. And so we had to remove it and choose a larger device. And so you always have to leave the field as good as you had planned it, so that I think we were removing it. And this is one of the ways to remove it, that is using a snare. You snare the device, pull it out, and you can see it coming out. You hold it tight, get it out of the system and off through the leg. And you have to leave the field as good as you had planned for it. If there's something in a different position, always take it out. I'll quickly brush through the PDAs. The VSDs, again, these are the types of VSDs that we have done, the perimembranous and the mainly and the muscular. And these are the size of the VSDs that have been there and the associated lesions that we have seen. And so that is the device already waiting to go. Let me see whether that, okay. And that is the VSD that has closed. Even if there is a small shunt, leave it, because chances are it will get smaller and close. So this is an antegrade approach. You now approach it through the right side, and that's how we check it, and that is how we close it. I think that's one of the complications of the PDA, and one of the things we do is to stent it and push it away. So this is the case where we had to just stent it and put it away. The other malformations that we sometimes do, this is a pulmonary atriovenous malformation, and you can see that down here there are devices that we have already put, and then we follow it up. We decided to do this in stage, so we left it at that and said we'll call the patient later again to see if we can withstand the procedures. When he came back later, the clubbing had regressed and the cyanosis had gone. So we still have him around. We are asking ourselves, okay, where do we go? We might have to put in a larger, because the shunt is there, we might have to put in a covered stent and cover that device. The lower part, there's a part of the lungs which is nice and working, but he has grown with that. Interestingly, we saw him this week in very good shape, and we did this much quite early. Other procedures that we do are echo-guided bedside. That is periocardiocentesis, and we just do it on the bedside. And this is also that we sometimes do it on emergency basis. And again, the complications and the fact that you have to retrieve them and leave the area as good as you had wanted. What are the challenges that we do face? You can't have life without challenges. We do have challenges in terms of our staffing. We still think in any of these hospitals, I normally think the staffing is still very scanty. And in the teaching hospitals, you'll have one or two major people, and then the rest are learning from you. So, and especially in the radiology unit, you have your nicely trained radiographer, and then it's taken away to the MRI, you have to start afresh. But those are some of the challenges we do. We did have challenges with contrast. This has been sorted out throughout the country, and we are very happy. And so one would be quite happy with a pool of staff that is just dedicated to the lab. Unfortunately, for all these hospitals, and especially for the private hospitals, they shuffle them around when there is need. So you find the fellow has run to the MRI to do something, back to the CT scan, then is when he's coming to the lab. So you do have challenges. The other challenges are the very sick and the cyanotic patients will have severe arrhythmias. Others will have systemic desaturations as you're working. Others, it is a combination of desaturations and arrhythmias. But at the end of it all, we get quite happy when this neonate who would have gone is doing very well, okay? And most of the times, it is all smiles. Thank you very much.
Thank you so much, Prof. Joy, for that wonderful presentation in terms of the scenario in our country and whatever you people are doing on the field. So I'm going to give this opportunity, Dr. Deepak, to lead us on a brief discussion because I think you are more or less peers. Then I'll take over from that again. Thank you so much.
It was a wonderful presentation, ma'am. I would like to congratulate you for the kind of work we are seeing happening in Kenya. I'm sure a lot of budding cardiologists will take this path and learn a lot from you. Having a teacher like you in such a nation is always a boon to progress the program further. Very happy to see the cases and very brave on your part presenting your complications also. So that was really delightful, very nice lecture. I congratulate you for the wonderful work you're doing.
Thank you. Thank you.
Good afternoon, ma'am, and wonderful and lucid presentation. We loved the visuals you showed and the kind of work you people are doing here. Just for our understanding, we also want to know about what is the scene in cardiac surgery, for pediatric cardiac surgery, how is it in Kenya as yet? And for all these kids, like complex congenital cases, usually is it like they're being operated in Kenya or some surgeons are coming and doing it here?
Pediatric cardiac surgery for a very long time has been in the capital city, Nairobi. And the story is very long, started in the 70s, the late 70s, 71. I know that in 75 they were quite busy. I was a student and we could see some of those cases. We never used to understand them. We're just trying to know the 5 T's. But they were doing they were doing something. And then it stopped. Then we started limping. They would do one case. And what used to stop us is cardioplegia. That's all. Then we became wakora. Wakora means means you become tricky, crafty. So we didn't have the president had a case and he wanted it done and he said we know you do. So we said, but we don't have cardioplegia. So using Kenya Airways, quickly cardioplegia was brought. He wanted that one case done. We quoted for 4 patients and we did 4 patients. Then he said, but then you can do them. So again he asked, I said, no, but we can't get this cardioplegia. The next round we were smart, we asked for more patients and we were capable of doing the patients for longer. That cardioplegia stopped us. The second time, it was consumables. We didn't have companies that are dedicated to bring consumables, something that is not an issue now. But it was such a headache. And so we would stop even for 3-4 years. So we stopped and then started again in 1984. And this is at the main hospital. When we started at 1984, we have not stopped. Our challenges now are the complex cases. We now have dedicated cardiac anesthetists and cardiac intensivists who work mainly in the main hospital, but they also work in the other hospitals because the main hospital does work. What were the main challenges? Initially, we were only given 1 theater day on a Tuesday. So even if you want to do 100, you probably will end up doing 50s. So other hospitals came in, and they came in at a go. The Nairobi Hospital and the Mata Hospital started almost at the same time because that's what we got. We got 2 heart-lung machines, and I remember carrying one as a luggage from Italy and being called once you are in the plane to come out and see what you are, and what is this you are carrying? So we got those donations and moved on. Now that is history. If you look at this, at the cardiac surgery, every hospital is now capable of doing the surgeries. Kenyatta Hospital is working on giving us more time, but we have two theater days in a week, and in that 2 theater days, we are capable of doing 2 patients in one day, so we're capable of doing 4, and occasionally we can get the other list for the thoracic and put in a few, but we still have those challenges. Other hospitals fully dedicated for cardiac is not there. They have to mix it with other work, and that is how we have been doing, but we are moving on. We are much better. We are now, the issues we have with congenitals, and let me put myself in congenitals, is that the pulmonary hypertension issue is still a lot, and that is where we refer, especially the young pulmonary hypertensives. And then, of course, we are not still doing much of the neonatal TGS that we are not doing. We did and had a few mortalities and sat back. And we haven't pulled up. I think we still cannot agree on a few things. And unlike and I'm putting this in the main hospital because in the main hospital we have a fixed budget. And once you have used your budget for consumables or for whatever it is, getting the other additional ones can be very difficult. So we have sat down and said, this is what we need for ABCD and tried to get that. But it takes us not throughout the year. As you wait for the annual other budget, the in-between supplementary budgets hardly helps us. But that is admin, and one day, if you have a cardiac center, then you can do your budget in the center, and that would probably be fine. But those are some of the challenges that we are facing in terms of cardiac surgery. They're capable of doing so much. In terms of valve repair, valve surgery, we have moved from the original just repairing the valve, just removing the valve to repairing it, because we have young children or very poor socioeconomic status that will not manage that dedicated INR checkup. So the valve repairs we had learned from one of the doctors who kept on coming on an annual basis, sometimes twice a year, and now the skills are there. The skills are there, and it depends on the surgeons, but those skills are now there.
Thank you, ma'am. Thank you very much for a wonderful presentation.
Thank you.
You should also stay for a talk later on. I'll also be discussing some valve repairs in my talk also.
Thank you.
Thank you.
So, Prof, before you leave, we are also online. So I've received 2 questions for you. So the first question is from Christopher Koti. He's asking that in pulmonary atresia, how does blood get to the left atrium and ventricle? Is there any associated VSD? So that's the first question. Then the second one is from Anonymous. What is the probability of other young siblings having a congenital heart disease if a senior one has one, or if other sibling has one? What's the probability? Thank you.
Some I might not know the real figures of 10%, 5%, 20%. But usually when we, and most of this is based on the individual history. Every time a mother comes, I actually look at the condition and ask, how was that pregnancy? Some are complicated, some were simple, some you find nothing. How was the delivery? And how has this child been? And that helps me know whether these people are likely to have chances. I know every lesion has its feasibility of increasing, but this is a very common textbook question. Maybe my colleagues will also help me in the answer in proportion of some of these cases.
Yes, of course, ma'am. I mean, if the SIB is there who's having a congenital heart disease, the chances of the next SIB having is almost 3 to 5%. And the best chance to detect a congenital heart disease in the next younger SIB is definitely even during pregnancy by fetal echocardiography. Okay. 18 to 22 weeks is an ideal time when there is almost a complete formation of the heart and the chambers take their actual architecture. And fetal echocardiography is definitely a big boon to terminate any complex pregnancies like complex congenital heart diseases, especially hypoplastic left hearts, where we know even after palliative surgeries and interventions, the child is still going to have a life till second decade, where he'll need a heart transplant because he's carrying a weaker ventricle with him, the right ventricle. But of course, I mean, the fetal echocardiography can also help in counseling the parents in case we detect some simple heart defects like VSD or ASD during that pregnancy. So we can always counsel the couple to carry forward the pregnancy, and it's a reasonably simple heart defect which need just one-time intervention, and the rest life will be fruitful. So yes, chances are there, 3 to 5% of the next SIB having it, and fetal echocardiography is an answer for that. We can detect it, yes.
Thank you.
Let's clap for our panelists and Prof. Joy. Thank you so much. You can now have your seat, Prof. So we are going to go to our next talk. So our next talk is going to be given to us by Dr. He's also a colonel, Manjida Sandhu. So he's an adult interventional cardiologist. We have brought his topic forward. It was supposed to be in the afternoon. So he's going to give us a topic on new advances in interventional cardiology. So he's a principal director of cardiology in Mark's Hospitals in Gujarat and Saket in New Delhi. So he has done a fellowship in India in a well-established institution, and also in the United States. So he has a vast experience, having done more than 30,000, participated in more than 30,000 cardiac procedures and more than 10,000 cardiac interventional procedures. So today we are going to learn from a well-experienced, renowned cardiologist in his field. So let's welcome him to give us the talk. Welcome.
Good afternoon, everyone. I think by well-experienced, he means that I am suitably old. So normally, I'm used to giving talks and showcasing certain procedures which you have done. This time, I was told by the organizers to talk on, latest advances in cardiology. So I've put forth a presentation. Some of the things are what we have been just recently launched or seen, and some which are going to come up in the near future. And this is just an eye-opener that what is in store for us in the coming months to years. That's Dr. Vadwani's presentation, by the way. So some of the things are truly amazing because I'm sure most of you would have heard about the hype of artificial intelligence, deep learning, and all those things. Some of these concepts we are already using, but we are not aware of it. And some are being developed at a very rapid pace, which will change our practice in the years to come. So first of all, I'll start off with cardiac imaging. What's in store with us for cardiac imaging? This is Siemens photon counting CT. Now, as we know, CT scanners have been there for a long time. They are usually looking at seeing the light impulses, total light impulses which are landing on the generator tube. And here, they are counting each photon. So you can imagine that we are now going to get exceptional clarity. So this is something which is the clarity which we can see on the photon counting CT. As you all know, that conventional CT scanners fail to give us the true lumen when there is a lot of calcium. So here in photon counting CT, we can isolate chemical compounds by their atomic number, like iodine or calcium. So they have this pure lumen where we can remove selectively the calcium and see the lumen of the coronary artery clearly. And then on the left, you see this kind of images, which is like an anatomical specimen. So the CT scanner is able to generate these mono-energetic images with really anatomical specimen-like detail. Then we have GE coming up with their Cigna series of MRI with 4D flow. Now what they have done is they've taken the normal phase contrast MRI, then they have tagged them, and now we get flow velocity information, pressure gradients, and all with velocity time integrals thrown in. So this kind of technology gives us a huge detailed understanding of the blood flow inside the heart. And this is in real time, and we can generate huge amount of information regarding valvular regurgitations and shunts with this 4D flow technology. And they have developed very validated reporting protocols, so which can give us very good understanding and reproducibility of these flow information. There's a company called CardioFlow which has gone one step further. You give them any phase contrast existing MRI, and they have a software which will convert it into 4D flow. And this is like the technology, you don't even have to buy the newer equipment. You maybe use your older MRIs and send it to them, and they will quantify the flow for you. So moving on to coronary imaging. So, I mean, we have all been using intravascular ultrasound and OCT for quite some time now. And now we have SpectraWave company has launched a thing called HyperView. So they have this proprietary OCT technology called Deep OCT. So they have run through the algorithms of the OCT images through deep learning neural networks to get advanced clarity. This, combined with near-infrared spectroscopy, gives us the whole kind of details through a single catheter, the Starlight imaging catheter. We get amazing details on the amount of calcium, amount of lipid, amount of vulnerable or high-risk plaques in the coronaries, which in turn helps us where to land and start our stents, and accurate vessel sizing and post-stenting optimization. So this is their deep OCT plus near-infrared spectroscopy solution. Then we have a company called Novasight, which has gone one step further. I mean, most of you would have seen that sometimes you have to use an IVUS and an OCT in the same patient. So these guys have got a single catheter which combines both the OCT and the intravascular ultrasound into a single catheter. So right at the tip, they have their the IVUS transducer as well as the OCT transducer. The advantage of having a single catheter is immense, because at any given time, you're going to get simultaneously co-registered images of IVUS and OCT at each length of the pullback. So this gives us very detailed information, plus it's also helpful. A lot of times when we do OCT, we cannot clear the lumen of all the blood, and we get very poor images. But with this, at least we can get a valid IVUS image registered, if not the OCT. So your run has not been gone in vain. So this kind of technology, I mean, is going to ease your cardiac cath lab workflows immensely, because you are going to get the images, both OCT and IVUS, and plus the understanding of both the lesions, their morphology, and where to start and end your intervention and planning your interventions adequately. Now, coming to coronary interventions, of course, we have always been, stumped by having a huge thrombus burden and acute coronary syndromes. Existing clot retraction catheters have not delivered on their promises of removing the clot. So, but now we have this one of the devices, which is the Penumbra, suction force of 28 grams, which can reliably suck out the clot, and without sucking too much of the blood. And they have this, a filter which can filter out the clot and the blood separately. And plus, it is combined with very good trackability, so that we can go distally also. A lot of times, your existing clot suction catheters like thrombosuction are very poorly navigatable, and they cannot go to the distal coronary vessel that well. So we have a new coronary wire. Nowadays, a lot of us are doing chronic total occlusion interventions. Whenever there is a blunt tip right at the coronary, we are using the antegrade dissection and re-entry techniques. So re-entry with the currently available Boston Scientific Stingray system is less than ideal, because the wire does not or is not able to puncture the CTO segment, but only after the CTO segment. And sometimes we cannot go that much of an intimal dissection, and it may be limited by calcium. So Conquest Pro is a very known coronary wire, known for its stiffness and helping us navigate in CTO lesions. And now they have sharpened its tip and given it extra teeth. And now this is suitable for re-entry from the dissected intimal space into the CTO segment itself, even if there is calcium. And of course, one has to be very careful, because it will go anywhere. It will go out of the coronaries also. We have been doing the post-stenting, especially if there's been a bifurcation, a bigger branch. We know that the stent is not optimized proximally, because we are sizing it up to the distal reference vessel. And then we have to do a proximal optimization and a distal optimization. So currently available balloons had this huge overhang. Now with the specific balloon called the pot balloon, the overhang is very minimal. So you can do a very exact proximal optimization and optimize your stents without distorting the area where you do not want a dilatation to happen. So some years back, I had this idea to develop this, but sadly, nobody took me seriously. We all know that we are doing ostial stenting. We keep the stent 2 to 3 millimeters outside into the aorta, and then we do more of a psychological flaring by retracting our balloon, which actually does not do anything. So now we have a dedicated balloon, which reliably flares the ostium and almost opposes it to the ostial opening of the coronary arteries. And the advantage is that I'm sure that most of the interventional people would know that if an ostial stenting has been done, re-intervention is almost impossible, because you cannot hook that vessel with the guide. But with this balloon, the flaring is so good that re-access is maintained, and we can do a re-intervention if required. Tackling calcium has always been on the forefront of our agenda as interventional cardiologists. We had rotational atherectomy for a long time. Now we had shockwave balloons to rupture the calcium. And now we have the orbital atherectomy. With rotablation, we could only achieve a certain degree of a lumen, 1.25, 1.5 millimeter burr. But with orbital atherectomy, with its circular grinding motion, the lumen area achieved is very much larger than the rotablation. And another advantage is that medial calcium is fractured by the orbital atherectomy, which is usually not touched by rotational atherectomy. Another big advantage is that blood and saline flow continuously during the procedure, unlike rotablation, where we just have the solution going in, and we have bradycardia. So we have hardly any bradycardia when we are using orbital atherectomy. The particulate size generated by this device is so small, is smaller than a red blood cell size, it just washes the way into the circulation. So we don't have the issues of slow flow, no reflow, as we have with rotablation. Then we have the Neximer laser launched by Philips. This system has a catheter which has got laser elements right at the tip. And it is indicated for a broad range of indications like instant restenosis, where we need to debulk. The mechanisms are, with a light pulse, followed by a sonic wave, and a cavitation bubble, which actually debulks that whole plaque. In fact, I was talking to one of these people, and he said, sir, they have seen amazing results when we have a thrombus-laden coronary. And when we do a balloon dilatation, all that thrombus breaks up into small particles, goes distally into the circulation, and causes no flow. But here, it just eats away all that thrombus. I asked him repeatedly, where does it go? He said, sir, it just disappears. So I have yet to try it out in one of these thrombus-laden lesions and see. But so far, we have been using it to, it's a very tough instant restenosis. It helps us to achieve a good lumen gain. And this is a very welcome, tool in our armamentarium to treat coronary lesions. Coming to heart failure, we know for a long time we have had this CardioMEMS implantable PA sensor, which didn't really cut the deal. And so now we have this direct left atrial pressure monitoring. So it's a simple procedure like a transeptal puncture, and you implant this device, very similar to a miniature ASD device. And then it transmits data directly to the cloud of direct left atrial pressure. And this band also charges the device. And this data is then used to adjust the patient's medication. So if you look at the care cycle, you can have the data being transmitted, then the analysis done on the cloud, and then sent to the physician. And then the physician directs the medication adjustment. So in one of the initial trials, they saw all nil hospital readmissions after left atrial pressure monitoring was instituted. So I think this is going to come up in a big way, because there's nothing like having continuous monitoring of the patient's left atrial pressure. And heart failure patients, you all know, are the most ill-managed, no matter how hard we try, because of both doctor-related as well as patient-related factors. Then, I'll just go back. So you see, all of our heart failure patients, only 70% are eligible for CRT-D therapy. Only 30%, 70% are not eligible because they do not have left bundle branch block on their ECGs. And as we know that CRT-D improves LV function radically, so certainly we have got patients who have achieved normal ejection fractions post-CRT-D implants. So, but we can give this therapy to only the 30% of heart failure patients who have left bundle branch block. So what about the rest 70% who are usually given an ICD, which does in no manner improve your LV function? So we have this two devices. One is this baroreflex activation therapy by CVRX. This is a device. It is surgically placed, the sensor, over the carotid baroreceptors. As you know, the carotid baroreceptors send the afferent information to the brain, and thereafter the efferent sympathetic and parasympathetic outflow to the heart is affected. But with this, stimulation of the carotid baroreceptors artificially by a device just like a pacemaker, we have all these positive effects on heart failure with improvement in, this is one of the initial trials with the baroreflex activation therapy, and we see improvement in exercise capacity, quality of life, reduction in NT-proBNP levels, very, very significantly from the controls. So this is a very welcome addition. We can offer this to our patients of heart failure who are not eligible for CRT-D. Another competing thing is cardiac contractility modulation. It has been there, the theory, for a long time, but now it's in practice, just like a pacemaker device. We have this implanted in a subclavian pocket, and there are 2 leads which are implanted into the ventricular septum. So these give high voltage signals during the absolute refractory period of the heart. And this therapy is given an hour each day with on and off cycles, and it results in a huge improvement in patients' quality of life and their 6-minute walk tests. In fact, I may be doing my first patient of a CCM in the coming week, and it has been launched in India. The cost is around 35 lakhs to the patient, pretty expensive, as in all newer therapies. In the structural heart, percutaneous aortic valve has been there for a long time, but we all know what is the problem with TAVI procedures? It's the emboli, cerebral emboli. So there's a lot of higher incidence of stroke as well as pacemaker, the 2 most things with TAVI. Now, we have a device called Sentinel, which has been there for us some time, but which protects 2 of the cerebral arteries and leaves the 3rd one unprotected. So this is an Israeli company which have developed a very, very simple concept, but it is very amazing. It's a whole body embolic protection. This is a translucent filter which conforms from the ascending aorta arch right to the proximal descending aorta. It has got an integrated lumen for the pigtail to do your shots. And then there is this port, if you see here, through which you can take any kind of a TAVI device, do your procedure. All the emboli are collected into this, and then it is simply retrieved. So this is a very good, I would say, development for almost having 0 emboli during all these, high-risk emboli-producing procedures. Then we have a new valve, the Navitor by Abbott. We know one of the other complications in percutaneous aortic valve implantation is the paravalvular leak, which we have been sorting out by doing some post-dilatation. But then if there is calcium, no matter what you do, the paravalvular leak will persist and sometimes may get worse. So we have this skirt which inflates during diastole and which seals the areas around the protruding calcium struts. So in fact, it's a very simple concept, but it works so beautifully that you almost can get rid of a lot of severe degrees of paravalvular leak. And then over time, the tissue grows in and it just becomes part of the aortic root. So this is a good addition. Then a lot of these patients with percutaneous for TAVI, we are unable to do because they have pure aortic regurgitation. As you all know, TAVI is indicated for only aortic stenosis, not with aortic regurgitation. And why? Why can't we use our existing TAVI devices in AR cases? Because there is no calcium for us, the valve to hold, plus the diameters are larger. So there's a high incidence of failure if we use in pure aortic regurgitation our devices. So this valve has been developed for patients with pure aortic regurgitation. And the thing is that this Trilogy system has been designed to have the structures for fastening the valve to the aortic annulus. They have these 3 markers which are placed into the sinuses, and they hold the valve there together. So you can just rotate, and it's a very simple procedure to do. Once you have this alignment, you can check fluoroscopically, align both the RCC and NCC, overlap them so that you know that you are in the right position. You can have transesophageal guidance also. And once you implant them into the coronary sinus and release, your valve is working, and it is going to be stable there. So this is a good indication. I think now a lot of patients with AR, combined AS-AR, would become candidates for this kind of a valve. Some people have taken it one step further. If you look at the aortic valve, what is preventing it from opening? It is the calcium deposition in the leaflets. So, I mean, another thought is that why replace the valve? Why not modify the calcium which is there, like we are doing modification of calcium in the coronary arteries with rotablation, with orbital atherectomy, with shockwave balloons. So this is LeafFlex by Picardia. So this is a device which scores the calcium on the coronary leaflets. So you have this kind of a frame which you orient, place it into the sinuses, and then there's an inner frame which pulls up and presses this against each other, thereby scoring the calcium. So if you look at that frame, it just scores the calcium at one point, and all you have to do is then rotate this to another position slightly and score the valve again. And there have been some dramatic results in aortic valve opening. I don't know whether the surgeons may understand it better. So they have shown a huge improvement in aortic orifice area after this LeafFlex scoring, and I think it's a welcome addition. So all these technologies, I think we are going to see them coming in the coming years and helping us, and maybe changing how we treat our patients in the near future. So at the end, I'd just like to end with a quote that new technology is not good or evil in and of itself. It's how people choose to use it. It is not the doctors should not get into the rut of trying to use the new technology just because it is there. Remember, we have to help the patient at the end of the day. So we have to choose the right technology for the right patient for his benefit. Thank you.
Okay, thank you so much, Dr. Sandhu, for that wonderful presentation. I'll invite Prof. Joy once again to join the panelists as we take questions from the audience. I can see Dr. Samia has also joined us. Welcome. So, any question from the audience? The floor is now open. A few questions, then we go for the lunch break. I know many are tired. Dr. Osman. I know you have learned something, so just ask. This is not a terrible question.
Okay, I'm just curious about, you said the coronary artery plaques, the calcium you can do shockwave and just dissolves their tiny minute particles, and they don't cause obstruction distally and just be washed away. But then this of the aortic stenosis, I didn't get why not approach like the same way, such that you do shockwave and just dissolve. Is it also possible?
So yes, in coronaries, the device is in direct contact with the calcium around. It's a circular artery. So we can ablate it by orbital atherectomy into smaller particles, and they get washed away, removed from the body by macrophages subsequently. But in an aortic valve, you can imagine, I cannot do that without destroying the valve. Let us say I devise a device which will do a circumferential abrasion, because here the leaflet tips come first and the calcium is behind that. So that's why the last thing which I showed makes sense, that you have this device which scores the calcium and makes the valve more pliable and opening.
Okay, so any other question?
From the new therapies that you've shown us, thank you for the presentation. Which one has the least recurrence rate from the ones you've shown?
Recurrence rate from?
For coronary artery stenosis.
I did not show any technology which would affect coronary restenosis rates.
Yeah.
You know, I was just showing in the coronary intervention some new balloons, some new wires, and new ways of tackling calcium and instant restenosis. You know, the laser is a big thing for debulking very tough lesions, even fibrotic coronary lesions, as well as instant restenosis and thrombus, as I mentioned. But none of the technologies I mentioned which will affect restenosis rates, there would be possibly newer designs of stents, but nothing new has come on that front which is radical. That's why I did not show it.
All right, so there's a question from online team. One is asking that, Mr. Solomon is asking, the new technologies come at a cost. Is it possible to have a hospital acquire multiple technologies? So I think this is more of healthcare system. Like,
I think it's a valid point that all new technologies come with a very, very inflated price points. The device manufacturers, under the garb of getting back their development costs, etc., I think personally do hike up the prices, which is not reasonable. So but sometimes newer technology can actually help us save money by not being the early adopters. Like, for example, comparing if you are setting up a new cath lab, rather than having an intravascular ultrasound and an OCT, you can just have a single device, the NovaSight hybrid. So it will save you money and save you time and workflow costs. So sometimes being late to adopt a technology can be a good thing. Like we have been in India. We have leapfrogged to a digital payment system where not even advanced countries are still doing it. You know, so sometimes it's better to be a developing country, wait for the time when you have the money, and possibly you may be actually saving money because newer technology has come in.
all right, so this is the final question. I think it was meant for Prof. Joey, but I think you can also chip in as a cardiologist. So the question is that for patients with coarctation of the aorta into adulthood, what are the interventions? Or do you see them in the pediatric age group? Or
should I answer?
All right.
So we have been doing adult coarctation of aorta patients. We normally put a stent out there, and we have the classical, there's a balloon called the BIB, the balloon and balloon, which has very good stability, because once the coarctation is in adulthood, it's not as elastic as it was in the child. And we have to be making sure the balloon does not slip. So with the BIB balloon, we have got a good this thing. And then if the risk of perforation is very, very high for a very critical coarctation, then we put a covered stent. We straight away go in with a covered stent so that at least any perforation or something, we should be able to handle it. Otherwise, it will be catastrophic. Before we even call the cardiac surgeon, the patient will be gone. But routine coarctations, which are not very pinhole tight, those we can just safely put a normal uncovered stent in it. I hope, Madam?
Yeah, I think so. It was in the adult. We've done a few in the adults with a few stenting initially, as we didn't have the covered stents, so they were just bare stents, and come back, and a few we have redilated those stents later on. Especially they're into adulthood, really. They were not really the pre-teenagers and the rest of it. So you do a job and you know you're going to come back, but the job you're going to come back is not a difficult one. Thank you.
How is a family? When someone goes under the knife, is the probability of survival or maybe losing a loved one? Kindly, could you help us understand what you go through?
If you look at the kind of consent forms that we sign, initially it was just one line. Nowadays, I think we have 4 or 5 levels of consenting that the patient or the guardian has to give. And one of them is we explain the risks we think are there, and they have to consent that they're likely to have those risks. We weigh the success versus the risk, and we prepare them, especially for the patients who we know are quite unwell and are likely to come in with complications. You really prepare them. If they don't consent, then you don't have to go in. If they consent, then it means they are walking along with you in the line. And again, then you go and do your best. So that's where we have been. And like I said before, we are not champions. And most of the times, if we feel this case is so complex, we bring in somebody. We used to send, but we bring in that fellow who is used to doing complex cases. We send them the cases. We even send them the CDs of the MRIs and the CT scans, so they know what exactly they are likely to come back with. Because sometimes it is the hardware that we don't have. And like I said, we are a general hospital doing cardiac work. We are not a cardiac center. And so we know our limitations. So we have to explain that consent well, including the fact that, yes, I might lose that patient on the table. Remember, the cardiologist does the work, but even the anesthetist talks to the patient or the relatives, and there's a level where the anesthetist signs in. So the anesthetist will sign in, the surgeon or the practitioner will sign in, and then the patient signed in. So that consent is an informed consent, wherever it is given. So they have to consent. But again, as a doctor, that kind of procedure you are doing, even for you, it is a do or die. So you're really going to do your best. And occasionally when we can't make it, we pull out our catheters and come out, rather than having a table death. And if we review our critical pulmonary stenosis, that's the one we know we have to do our best. We probably would wait and check, do we have all the hardware? If not, have you borrowed from so-and-so, so that this patient, you do your best. Those are some of the things which we have been tamed and come down to see that we have to plan that procedure very well. Sometimes we gang up. If we gang up and make sure that everybody is available, everybody with this technology or just the ability to be patient when things are worse is there. So we pull out all the resources that we have, both personal and the hardware, to do the case. Have I answered your question? Thank you.
Okay. Thank you so much. And Dr. Osman, I'm not going to take your question because the time is well spent. I want to honor our morning team. They've given us really an informative discussion involving the pediatric cardiology series and also advances in adult cardiology interventions. So I think we should give them a hearty clap. So thank you so much. So we are going for a quick lunch break just outside here. So let's take at least 20 minutes so that you can finish early, because today is the final day of the conference. So in the afternoon, we are going to have more discussion on the adult cardiology. We are also going to explore the cardiothoracic field in terms of interventions and the latest advances. Then also Dr. Samia will also give us a talk in the latest acute coronary syndrome with the COVID-19, related to COVID-19. So thank you all.
Biometric Cables, or BMC, a global competitor with humble origins, an Indian business story. At Biometric Cables, we value the freedom to explore new ideas and seek to differentiate ourselves from the regulars in the minds of customers. We choose and manufacture products based on the law of value. Your true value is determined by how much more you give in value than you take in payment. Biometric Cables, or BMC, was founded by Arun Kumar Chidambaram.
Biometric Cables started its operation in the year 2005 with 4 personnel and single product line. Today as we speak, we have around 3,500 plus products and expertise with 10 different value chains. We have over 5,000 plus customers.
We manufactured ECG cables, pulse oximeter sensors, NIBP cuffs, contouring accessories, and later breathing circuits. By 2011, by staying true to our values, we were the first company to manufacture ultrasound transducers in India. We were able to realize the product at one location for 4 of our product lines, having been accepted as trusted supplier for ultrasound and breathing circuits with hospitals and OEMs. By 2012, BMC had moved into factory-cum-office in a premier industrial area in the heart of Chennai to meet the demands.
We at Biometric Cables would like to go deep rather than going wide. We would like to be identified as experts in the medical wiring harness industry.
Exploring further, by 2016, we were the first company in Asia to manufacture galvanic oxygen sensors and flow sensors for ventilators, and are one of the very few companies in the world that have the capability of manufacturing these O2 sensors.
With my previous experience in product design, I always had a dream of designing intuitive products. The product realization process in BMC has challenged me to develop high-value products for the healthcare sector.
With the COVID-19 pandemic beginning in 2019, then Government of India, as were the rest of the world governments, was looking to procure 60,000 ventilators. It called upon Bharat Electronics, an Indian defense company, to produce 30,000 units. Oxygen sensors and flow sensors are crucial components in ventilators, and BMC was the only company in Asia capable of producing them. In collaboration with Bharat Electronics, BMC ramped up its production from 250 units produced per month to 15,000 units to meet the requirements within the deadline. We were happy to be able to assist during times of emergency, and it filled our hearts with pride, knowing that our company rose to the challenge of saving precious human lives. We at BMC believe growing our people, along with the requirements of company and market.
வேலை செய்யும் தொழிலாளர்கள் திறமையை மேம்படுத்துவதிலும் புதிய தொழில்நுட்பங்களை கற்றுக் கொடுத்து தொழிலாளர்கள் அடுத்த கட்டம் செல்வதற்கு உறுதுணையாக ஊக்கப்படுத்துகிறார்கள். இதனால் எங்கள் திறமை வளர்த்துக் கொள்வதும் மேலும் புது திறமைகளை கையாள்வதற்கும் இங்கு உறுதுணையாக இருக்கிறார்கள்.
Today we employ 100 personnel with more than 60% of the staff having been with us for 6 years and above.
ஆரம்பத்தில் வந்து டீம் மெம்பராக ப்ரொடக்ஷனில் வந்து ஜாயின் பண்ணி ஒர்க்கு ஸ்டார்ட் பண்ணேன். இப்போ வந்து ஃபைனல் குவாலிட்டி கண்ட்ரோல் வரைக்கும் வந்து வந்திருக்கேன். நல்லா ஒர்க் பண்ணுறாங்கன்னா அவங்களுக்கான டேலண்ட்டை வந்து கண்டிப்பாக வந்து இம்ப்ரூவ் பண்ணி அவங்களோட அடுத்த ஸ்டெப்ஸுக்கு போகிற அளவுக்கு வந்து ஹெல்ப்ஃபுல்லாக வந்து இருப்பாங்க மேனேஜ்மெண்ட்டு.
We have gained the trust of over 5,000 plus customers, all attributed to our core values of delivering derived product value, service solutions, and continuous improvements in our products.
Biometric Cables sincerely believes we have to grow our people to meet the demands of the customer and the company.
We intend to stay true to our mission statement of sharing a common national vision of making India products for global markets. Biometric Cables, or BMC, A global competitor with humble origins, an Indian business story.
Meet the Kenyan doctors, men and women who work tirelessly not only to heal the sick, but also to set the national agenda in the health sector.
The doctor occupies a position that no other professional occupies. We, as doctors, are the ones that are closest to human suffering and human hope.
It all boils down to the patient. It's the public, it's the people we engage with. It's all to make sure that at the end of the day, we can serve the public better. We can ensure that there is quality healthcare out there.
These doctors have banded together to form the Kenya Medical Association, KMA, a professional body that promotes the practice of medicine in Kenya. KMA's mandate is to uphold high standards of medical ethics and conduct, advise the government, other medical bodies, and the general public on matters related to health, promote the welfare of doctors, maintain the honor and interest of the medical profession, support continuing professional development, and liaise with peer medical associations around the world.
Getting a degree doesn't make you a professional. Getting a degree gives you a medical qualification, an academic qualification. It is by being an active member of your professional association that makes you a professional.
So the people you associate, they're your peers who recognize you. Those are the ones who give you the way to professionalism.
Just that networking, professional development, in the social interaction as a doctor, because we work a lot, many hours spent with patients, so the only time is when you associate with other professionals and other people.
The year 2018 marks the golden jubilee of the Kenya Medical Association.
KMA was founded in 1968. And that's why it's turning 50 this year.
But KMA is actually older than that, because prior to registering Kenya Medical Association, it was a branch of the British Medical Association. So all our seniors used to be members of the British Medical Association Kenya branch.
The 27th of November 1968 marked the birth of the Kenya Medical Association, when it attained complete independence from the British Medical Association. Professor J.M. Mungai was elected as the first president of KMA. Dr. S.S. Dillon started his practice in 1954. He'd go on to become the chairman of KMA and mayor of Mombasa.
Before the KMA, I had joined the British Medical Association. It was nothing very special, it was quite normal, and we also changed our name from British Medical Association to Kenya Medical Association.
Dr. Joseph Aloch qualified as a medical doctor in the 1960s and recalls his early days in the association.
I did not know much about KMA. I heard about it, but it looked like an elite club of a few old doctors, mainly Asians, actually 99% Asians, used for dining and kind of chatting. On 5th November 1971 at 5 p.m. on a Friday, I was picked up from the new, we call them those days, new doctors' flats. They had just been built, and we were the first lot of doctors to occupy them. So at 5 p.m., a group of CAD police officers came to pick us. Why? Because a strike of doctors had been declared for the first time in post-independent Kenya. Unfortunately, most of the ring leaders had disappeared. So the police could not get them. So they are avenging, they're throwing the revenge on innocent doctors who are just doing their normal work. Myself and the late Dr. Mbaka and Dr. Gilbert Okelo, who is next door in this house, were taken to Karen police station and handled in. While we were in the cell over the weekend, the KMA, that time the chairman was the late Dr. Nesbitt, so he consulted the then KMA
is well known.
Other committees in KMA include the mid-90s saw a drastic change in the leadership vision of KMA.
Probably one of the most memorable and tumultuous elections of KMA in 1996 in Kisumu. When my name was proposed, I campaigned and I became the new president of Kenya Medical Association. At that point, then we decided that our taking over was not always going to be symbolic, but we were actually going to do things differently. And that became, I believe, a major turning point for this association. The first thing is that we started identifying, number one, key social programs that would respond to the felt needs of members of KMA, young or old. So, number one, we remembered when we first came to Nairobi as young doctors doing postgraduates that we had to fight for nearly 1 year just to get housing. That is where the housing cooperative comes in.
To date, the housing cooperative has done us very proud because, as you are aware, we have actually developed estates starting from the first one in South Sea, which is called KMA Estate. Subsequently, there was one in Otiende, KMA Otiende, and then we've had one on Riera Road, just near the junction shopping mall. And the last one now that is going on is one in Mtwapa, which is a high-end facility. The model of KMA housing is that you subscribe as a member, so it's a circle. And when there's a project, then they look for project financing at discounted rates, very good interest rates. And so you can either get a loan, or if you have the money, you pay it upfront and you get your property.
We felt that one of the biggest problems that doctors have is that they are uneducated in business. And I came across this when I went to my bank one day. And at that time, with that kind of salary, you don't see the bank manager. It's interesting that when I went to my KCB bank, the branch manager said he wanted to see me, and I was told by the teller that the bank manager had said that next time you come. So I said, why would you want to see me? Because he says that you are active in KMA. So I thought that he was going to calling me because my bank was in the red, because it was always in the red anyway. But it was surprised that he told me that, I wanted to see you to see if we can help you and your association. If you don't mind, I would like to have a chance to talk to your members about making money work for you instead of you working for money. Because I think that you people work too hard for the money, but the money doesn't work for you. That became an interesting thing. It happened during one of the branch during that dinner where doctors come with their files and I was asked to make comments that the president of the association had told that he wants me to put it this way. And I approached this idea that we would like, and we are working with private institutions
and lend 10, 20 million to doctors. So now doctors have the SACCO and they have the housing. So people borrow from the SACCO and put in their housing. So that was also a major achievement in that period.
An energetic team of doctors ushered the new millennium in, ready to tackle the evolving health landscape.
One of the things that KMA HIV committee did was to partner with corporates and to make ARVs, antiretroviral drugs, available at very good prices. At that time, when a course for 1 month will even cost about 50,000 to 100,000 shillings, with partnering with corporate pharmaceuticals, they made this accessible, and the prices came down to less than 500 shillings. This was a great achievement. Of course, there was the issue of training, training doctors, training nurses, and training pharmacists.
I have a very strong feeling that is what actually brought me to government. Because after that, when we said it could be done, people could be treated, and we have put a system of treating. I was called by the head of the civil service then, with Dr. Muga, who was the director of medical services, and Mr. Godu, who was the PS. A month later, I was asked to be DMS.
The opportunities availed and doors opened by associating with KMA cannot be understated.
I decided to do pathology immediately after my internship, and I had to go and apply for scholarship from the ministry. And when I went, I was told, "You are crazy. I mean, you just finished internship, you have to do 2 years." And I told them, "Why do I need to do 2 years of cesarean sections and other things when I want to become a pathologist?" So somebody refused at the provincial level then. I was told, if you want to be assisted, you better go to see the DMS. So I mean, for most junior doctors, or anybody for that matter, DMS office is such a big office. How do you? But because I had been with KMA for 2 years by then, I had interacted with Professor Richard Muga in very many circles, because as a DMS he was a member of KMA. Then he says, "But is there anything you have done? Because the reason why you have to work for 2 years is because you build a CV, you know what you have done." I had done a lot for East African Medical Journal, even published some articles, again, because of my interactions with people like Professor Lore. So I had all my dossier there, and I gave it to him. And as I was walking away, he told me he'll call me later, but as I was walking away, he called me back, and he says, "Go and pack your things and start. We'll find a way."
I think KMA has gone through a lot. KMA is alive, it's vibrant, it brings us together. It gives me a reason to associate and network with my colleagues.
I do not think there's any other place that a young doctor can sit with an old senior doctor and discuss things as equals other than in KMA. Because you know, in the hospital environment, it is very heavily regimented. We practice medicine almost like the military. So that if I am a senior doctor in a certain area, then people must respect me, people must give way whenever I say something, people must consider it seriously. But when we sit as colleagues in KMA, we sit almost as equals, because we can listen to everyone. Every idea is welcome. And it is those ideas from the young doctors that have helped to transform this association to the vibrant, outgoing, and visible association that it is today.
I mean, this is an institution that has exemplary skills, number one, in-house. It has potential to grow this. I mean, within the region, we're leading. We're the strongest within the region. So aside from offering leadership in terms of the regionally, we stand to push, one, our agenda. It's actually our agenda in ensuring quality of health is delivered to the citizenry of Kenya, in ensuring that all Kenyans have an access to a skilled health worker. Number two, can be able to afford these services that they require anytime, rather timely.
KMA Center in Upper Hill, Nairobi is a state-of-the-art business center comprising office spaces, restaurants, and apartments. It is the pride of KMA.
The vision of KMA Center was to be a self-sustaining project to
provide continuous funding for the association so that the association can concentrate on its core business of providing health to the country and being a doctors' welfare association.
So the KMS Center was part of the team that started it from simple paper. I remember working, we had meetings for very many hours, discussing the plans, discussing the approach, the strategy to use to recruit people to join the vehicle that was going to invest in it. And for us, the biggest achievement was actually putting up a 2 billion commercial structure in Upper Hill. And we had the President of the Republic of Kenya opening it. As a profession, doctors have been seen not to be entrepreneurial. So we took a big risk, and I think it just went to prove to the other associations that it's possible, that professionals can and should be involved in entrepreneurship and building this economy.
With the eyes of the world focused on access to universal healthcare, KMA is fully engaged in advocacy and policy development, laying the groundwork for the future of healthcare.
It's not doctors alone that can change the health system. It's impossible globally. It's not the nurses. Neither is it the pharmaceutical companies or the insurance companies. Healthcare is like an orchestra where you have everyone playing the instrument at the same time to produce music. Doctors are one piece of the health system. Professionals are one piece of the health system. And then there is the industry, there is the pharmaceutical sector, and there is the healthcare financing sector. All those subsectors put together produce the health sector in totality.
The entry of executive CEOs also starting to professionalize the activities of KMA. Without those changes, KMA would not be where it is.
Picking another SDG on gender equality, KMA is very particular about that. We've had the first president of Kenya Medical Association, the chairperson, been a woman. That tells you a lot. We've had the first CEO being a woman, the second person, telling you that there is room for us to also push towards their third rule as per the laws of this country.
In 61, 62, when I was in Mombasa, okay, I was with local authorities, but then other doctor says, oh, we are members of KMA, and so I joined KMA. But as a female doctor, when you go there were either you are alone, or there may be one or two ladies, and when you talk to your male counterparts, they would just say hello, hello, and there won't be any further talk, and you feel isolated. So one would avoid sort of going too much to those meetings, you see. There is a big change to the extent that this year even your conference is dominated by female doctors in organization.
I'm really happy to see a lot more younger doctors who are not only becoming members but also taking up leadership positions within KMA, because I think that to me symbolizes that KMA has many more years ahead of us, that KMA will outlast us.
As a young doctor, being a member of KMA, I've benefited quite a lot. Number one, it builds your professional capacity. You're able to interact with a lot of senior doctors who, number one, they mentor you. Number one, they grow your leadership skills. Usually, if I was not a member of KMA...
Internationally.
Now we are interacting even wider, and I think this more so in the last 2-3 years. We have engaged more within the Africa region. KMA championing for the formation of a Federation of East African Medical Associations. The greatest link having been, I think, with Uganda. We attend each other's conferences, and we have football teams that play very serious games, and you know, there's always who's going to win this game. So that's the Matthew Lukwia Cup. And further than that, we've gone onto the world, the global front. So KMA is now interacting greatly in the World Medical Association, again interacting with members from all over the world who are members within the association. And again, the common thread is that as medical associations, as physicians, our challenges are so similar. So when we listen to each other, interact with each other, we can build each other up.
Over the last 50 years, the Kenya Medical Association has played a crucial role in the transformation of the health sector, emerging as a leader in engaging medical practitioners and the voice for provision of the highest standards of healthcare in Kenya and beyond.
God or nature gave us a disease in the proximal part of the arteries. Those arteries are developing blocks from inside, and when you are trying to open it from inside, you are going through the muck, you are going through the dangerous area, the area which is anyway prone for the disease. What bypass has always done is that chosen the area where nature chose not to give the disease. So where there is a disease, the chance of recurrence is more. Where there is a disease, the chance of complications is more. But when you choose a nice, virgin, clean artery and connect a nice, clean, virgin artery to that, all you need to do is do it skillfully. If you do that job skillfully, and first 1 month, 6 weeks are over, after that something new coming there is not easy. So either you have done a bad job, or the patient doesn't go for a secondary prophylaxis. So the importance of secondary prophylaxis was well documented, and that is something essential for both stenting and bypass. So as physicians, we request you to make people aware of both the primary and secondary prevention, because disease is not being treated by either stenting or bypass. Both these are palliative measures to establish the flow again, that's all. So what is new is something that we all agree, and that's the whole thing, that now small is big. And whatever we do with 25 centimeter incision, now we are trying to do it with smaller and smaller incisions. The technical expertise required for that is something which is being evolved over time. And in bigger centers like ours, this is something what you see, the daily routine OT is like this. When you do a procedure like, so this is a Lima harvest being done, the left internal memory artery which has been harvested. So absolutely one thing I'll say, bypass surgery continues to be the gold standard treatment against which any therapy so far have come is being compared and yet not given better results, and unlikely to because of the principle I told you. And there is no comparison of a good internal memory artery to the LAD. So this approach, what I am telling you right now, is something we have adopted more and more in our hospital, where we do a minimally invasive bypass with a small incision. This is the flow of the internal memory artery, which is going to be connected to the, this is the left anterior descending artery, right there. It is just right there. With this approach, you are reaching the internal memory artery right there, connect Lima to LAD, and that's it. This one small incision with this one procedure makes up for all the difference between the superiority of the bypass over any other therapy. Lima to LAD. After that, what you do with other vessels is important, but that's not something very monumental in the long-term results. So this is how the setup looks like, this is how the incision is, and eventually this is what the overall patient satisfaction level is. Because it's such a small incision, 5 centimeter incision. Now, if you are able to do all 3 grafts through this, great. But if you are not able to do, even if you go ahead and do a hybrid procedure, like if you have just done Lima to LAD through this approach, and after that you put 2 stents in LCX and RCA, the surgical results are equivalent. The superiority of the bypass, which no other procedure has shown, this procedure actually showed in a very limited number, but the problem has always been the cardiac surgeons and cardiologists never really come in the same place, and the hybrid theaters are very far and few. But this is the eventually the best possible procedure in the longer run. Same way, when we talk about small is big, so Bental's operation is when you're actually replacing aortic valve along with a whole of ascending aorta till the carotid vessels, and re-implanting the coronary artery buttons back to the graft which you are placing. So such procedures are now being done routinely with the mini Bental approach. And mini Bental is a small incision, it's hardly 9 or 10 centimeter incision, where you replace the ascending aorta. Whole thing is done with 9 to 10 centimeter incisions. Mitral valve again, now most of the mitral valve procedures that we do are minimally invasive. So the incision is big just because you have to put a valve through it. If the valve was foldable, probably the incisions also would be smaller and smaller in the longer run. And that we are able to do because new materials have come. So the materials that we are using right now is, when you have such a small approach to the heart, such a small window through which you are working, your finger is not going to reach inside and tie the knot for you. So this sort of a new device which has come made our life really easy and happy, because there was always a debate between the efficiency of a minimally invasive valve when you do it with a small window, and sometimes the knots which you are tying becomes loose. You're not able to tie it that well. So this problem was, thankfully they're not very expensive to have. What more is new in cardiac surgery is the biomaterials. The biomaterial changes have happened in such a way that now, previously when we were doing redo surgeries, redo congenital heart defects, redo issues, so when you're doing surgery for the first time, God has given you a good, nice pericardium. That pericardium you can use, but for the redo surgery, pericardium is exhausted, and there was no really good material which eventually will not create a problem. So CardioCell, it is a tissue-generated, tissue-engineered bovine pericardial tissue, where you can use it as good as a normal pericardium for the redo surgeries. This has really helped create a lot of children in tetralogy of Fallot, when they go for first surgery at a very young age, they develop pulmonary regurgitation. So at the second time when you're doing the surgery and you use this sort of a tissue to repair, it wouldn't calcify again. And the latest buzz in cardiac surgery community right now is something which I think for pediatric and adult, both aortic regurgitation, aortic stenosis patient, now we have something what is called as the Ozaki operation, and the extension of this procedure has gone into the Bentals operation also, in the pulmonary valve implantations also. So there is one movement on the cardiology community about the TAVR, where they take pride in the fact that through a femoral artery, you are able to put the valve in the position and the valve remains there. Of course, they do not remove the existing valve. That is the biggest fallacy of not opening the chest. But a surgical step where you open the chest and do it inside, surgeons were never confident to create a valve in situ because it required so much of a precision and such excellence in suturing and measuring that every time it used to be a custom-made valve which you were just implanting. Like I showed you in the picture before, a valve is being stitched there. You are not creating the valve. But Dr. Ozaki, with his hard effort, has now perfected a technology where patients' own pericardium, when it is being used as an autologous pericardium. So to me, the latest good material for adult valve surgery is age-old autologous pericardium. And with this pericardium, when he cuts each and every leaflet and he sutures it with a perfected formula where you measure every sinus, where you measure every valve leaflet, where you reimplant the valve in the way he has taught, the results are really reproducible. So this is something similar to what was happening with mitral valve also earlier. So in 80s and 90s, Dr. Alain Carpentier in France was trying to repair mitral valves, and initially he was really ignored because nobody believed that mitral valves can be repaired. But now practically every surgeon worth his salt does mitral valve repairs. Same way, now there are at least 20 centers in India which are doing this procedure, including ours, where we do Ozaki operation with reproducibly good results. And once your own bovine pericardium is there, there is at least 10 years follow-up now available, and 15 years follow-up also is just about to be published, with more than 97% patients at 15 years having a competent valve in there. Why does it work so well is because essential part of Ozaki is in any synthetic technology where you're putting a stented valve there, be it TAVR, be it a surgical valve which we implant, the difference lies in the fact that Ozaki is a hemodynamically very, very, very resilient model. Sorry, my pointer is misbehaving. So this is the diagram with the 3D and MRI they had studied. So it is the same valve when it is closed during diastole, and during systole when it opens, you can see there is an appreciable dynamic change in size. When the heart is contracting, the whole aortic root and the aortic valve is dilating. That takes away all the pressure, all the wear and tear, because of which usually in the long run valves fail. So this valve leaflet is subjected to less shear stress and strain and eventually lasts longer. Because it is your own autologous tissue, chances of immune reactions also is less. So the longevity is theorized, and Dr. Ozaki in his results have perfected it, but the rest of the world is yet to catch up because most of the world started doing this procedure after 2015, and in India it is as recent as 2021, 22 we started doing Ozaki operations. Other thing which has changed our life right now is robotic cardiac surgery. This is the buzzword right now. Robots are being bought in India in practically every hospital. And as the world is changing now, most of the things we are trying to do, this is a new novel thing for us. It is a baby step for us right now. But very likely this will be the mega trend in cardiac surgery eventually, that all such surgeries will be done with a robotic help. And this is again the recent advances which will take it farther. So eventually this is a result of a mitral valve replacement patient. You can see with this incision, whole mitral valve replacement was done. So small is big, and modern technology is helping us. And the same way, TAVR, excellent procedure. I really appreciate, beautiful procedure. If you choose your cases well, particularly for the patients above 65, 70 years of age, I think TAVR is the best possible procedure. When you know that this is the last procedure you're going to do in this patient and the redo is not likely, that's the best time to put TAVR, according to me. But even if you're putting it early, be prepared that after 5, 10 years, you may have to go re-intervene and put another TAVR valve within the valve, which is a mess, definitely a mess, whatever type of valve it is. The surgical equivalent of this TAVR valve, or the surgical precursor of this TAVR valve during the process when the TAVR valve was being researched, is the Percival valve. So Percival valve is something where, again, surgeon is trying to avoid suturing, because suturing through a small incision is very bad. And when you want to do small incision surgery, sutureless valves again give you a very good tool. To me, again, Percival is used to be used for people above 65 and 70 years, where you know you're not going to go back. If you have to go back again to explant a Percival valve or a TAVR valve for a surgeon is a mess. Now we all know life expectancy is increasing, and most of the developing worlds are catching up with the developed world. India is very much there, and I think your country also has reached a level where at 65 years of life expectancy is there at birth for you guys. So the burden of life expectancy rise is felt in the society. When the infectious diseases don't remain the primary killers becomes heart failure. Heart failure surgery is something which I am most passionate about, and that's where I think the most recent advances have helped us tackle things. You heard about the ECMO from my dear colleague here, and ECMO is something eventually will be used like a ventilator. Like in most of the hospitals 20, 30, 40 years back, ventilators were not available. I assure you, after 20 years, ECMO will be available in each and every unit, because this is the ultimate life-saving support mechanism. And now it has been taken to a level where you can stop heart and lung totally. I mean, even if your heart failure has caused some dysfunction, you can bypass the heart and lung and keep the patient alive till you fix what was the primary problem. If it was just a temporary problem, you just switch off the ECMO after some time, patient will come back. And if it is not, at least you will know what to do and think what can be done in the best possible way till patient is being surviving on an ECMO. So now it has taken a situation where in emergencies of the hospitals and in ambulances also, in US and Europe now there are programs where even in ambulances they have facility to install ECMO. In India this is yet to happen, but there are hospitals in India now where we have facility in the ER department. So for a patient who is being revived, and if suppose normal CPR is not effective, it becomes a eCPR where a ECMO is brought in for a CPR. Similarly, in the cath lab, they use tandem heart and impella as a mechanical support devices. That is the next big thing, which I'm sure even Kenyan cardiologists will be very happy, and soon they'll be using it, if they're not using it already. So I'll not dwell too much into the algorithm of eCPR. And as my predecessor said, just the perfect mechanical support for the heart is another heart. So heart donations and organ transplantation is the key. No other mechanical circulatory device can replace a heart. A human heart is the best replacement for a human heart. And organ transplantations systems are being robust nowadays. India has growth so much, shown so much growth in last decade or so. There used to be hardly less than 5 heart transplants in the country 10 years back. Now the number have reached up to around 400, and it is rising every year. So the different states, different governments are implementing within the India the protocols, and hopefully with those protocols we'll be able to do even better. But yet vast majority of population will never get a heart. So heart failure burden is so high across the world that to support them in the long run, eventually it will fall back on devices because heart's availability will always remain low compared to the demand. And that's where technology comes in. The most durable long-term support besides a heart transplant is the LVAD, the left ventricular assist device. So putting such a device inside the chest of a person with a wire dangling out is the model right now, so it is not very popular. It is also very expensive. But once we have the technology that we will do away with the wires. So the current most popular LVAD is, sorry, it is not working. Yeah, this is the HeartMate 3. This is the most popular LVAD device currently. And sooner or later, like an iPhone can be charged wirelessly or a Samsung phone can be charged wirelessly, the batteries of pacemakers are implanted inside already. Just there is one technological step far that if there is a totally implantable heart or a left ventricular assist device heart, you can implant the battery subcutaneously, and that subcutaneous battery, if it is being charged transcutaneously with a pad, magnetic pad, that will take care of whole problems with this procedure, and then it may become the mainstay procedure for the heart failure patients. May even compete a heart transplant eventually someday. But technology is there to improve the life, to prolong the life, and to take care of all the sickest of the patients. The heart failure, right now the heart failure treatment falls onto trying to avoid repeated admissions. Eventually it'll be like how these people have played, they have gone gymming, these people can play football. The cardiac output these machines can deliver can be up to the 9-10 liters per minute, much more than an average normal heart. So this transcutaneous technology, when it comes for battery charging, we will see a resurgence in mechanical circulatory support devices for the long term also. This is one such example. This young African gentleman in US was in waiting list for heart, unfortunately fell sick. He became very popular because after he received a mechanical circulatory support device, he started bodybuilding. He became a model for, his name is Andrew. So this guy became a model for such people with such a machine and a wire dangling out of his body. He lived with that for 11 months and eventually got a heart transplant. I'm sure he's happier with the transplant. Taking care of wire is not an easy job as of now. But it is possible. And such a physique, such a body, one can manage if after a LVAD also. The biggest difference right now is team approach, because right now the complexities of the treatments are so many that interventional cardiologist and cardiothoracic surgeon alone are not the part of the whole equation. We are just two of the many heads required for it. So heart team approach is eventually requiring a non-invasive cardiologist, an interventional cardiologist, anesthesiologist, ICU people, physiotherapist, trained physician nurses who help in overall management of the patient. That the approach or the philosophy of the treatment is what is the need of the hour. And eventually that will show us better path, because right now there are so many different diverging paths that it is confusing for everybody within the community, within the medical community, and outside in the society also. Hopefully we'll finally come to a path. When you look back, probably there'll be one road to go as a heart team. Thank you. Thank you very much for your patience.
I thank you, Dr. Mahesh, for that wonderful talk. So we have come to an end, so I'll take the last few questions before we wrap up. So the floor is now open, so we can ask questions. We are tired, eh? You want to go home? You're not going home right now. Maandamano nimeanza. All right.
Yeah, that was a wonderful presentation, Dr. But I want to ask our Kenyan cardiologists, why do we refer our patients to go to India? Is it because we do not have equipment, or is it because we are not competent in that area? Because most of the time we see our patients are referred to India, and the cost of the whole process is a bit expensive. So what are we learning from this Congress? What's our take are we going to enter into an agreement that we look at the cost implication of this thing, or we are just doing this for the purpose of doing it?
Thanks for that question. Maybe I'll give us some suggestion, and Dr. Jelan will also make a comment. Now, the decision of where one is being treated is highly individualized. We have systems that take care of the health of an individual. If you belong to a healthcare scheme, for instance, it may prescribe to you that when you are sick, you'll go to facility A. Where A is not able to manage, you go to B, C, and D. Many of our private healthcare systems prescribe that too well, and they would restrict the treatment of Kenyans to Kenyan health institutions. Same thing with government facilities. Individuals also take care of their own health issues, and like you had the discussion before, because of certain factors, some individuals would want a certain level of privacy and so on, and would not want to be treated around, because sweeper X who comes in the room will go out there and whisper, so-and-so is admitted here, or nurse so-and-so would do. So such an individual obviously will go not just India, but any other place out of the country for treatment. This does not in any way mean the condition they're being treated for is not amenable or treated within the country. But they're using their own resources, they can go and receive their treatment wherever they wish. Where there is a public health system involvement in paying for that health care, they may restrict that and say, we will not support you because this treatment is available locally. That's one angle of looking at it. The other angle is we have had development of cardiac care in the country. The recent few years, we've seen a lot of improvement. A few years back, we didn't have cath labs or cardiac care units in the country, robust ones like what Dr. Jelan has just shown you. Cath labs have come up, cardiologists have been trained, surgeons are there, intensivists are there. So we are proud that as a country, we've had a growth in these facilities, human resource, and so on. So many of these diseases, probably 5 or 10 years back, we, true to itself, did not have an option of how these individuals would be treated. They had to go out. Now they can comfortably be treated within our local environs. Of course, we have those diseases that are complex in their own nature. One would say this one, with the facilities and expertise and what we have, we cannot handle. Maybe you seek this treatment elsewhere. I think you had the talk of Professor Joy this morning. She told you very well. We don't have robust, specialized cardiac centers. Every day, that center just does bypass, and nothing else. Here you are competing with neurological issues and so on for the same beds, for the same theaters. So obviously, your expertise and so on may not be as good. So we may have true deserving cases that need to be referred to specialized centers, not just India, but anywhere else where these facilities are available. And I think clinicians, as clinicians, we have to be true to ourselves and say this one cannot be handled, seek this treatment elsewhere. So we need to change this dynamism. And exactly who sends patients to India or out? Patients themselves, clinicians, relatives, politicians, and so on. So we need to tackle all these individuals and tell them, educate them, you being part of that team, that we have this form of treatment readily available. You can actually receive this treatment locally. You do not need to go out. And I think the other thing that is happening, even some of these facilities in India and so on, maybe they find it more cost effective to come and set up those treatment units locally so that they would have a wider catch if a certain specialized form of treatment is available in their country and they come and set plant in Kenya, they would have more patients to receive that treatment here.
Thanks for that talk. I really appreciated it. And I will ask you something about the Ozaki procedure afterwards. In response to the question, I think Dr. Sami has covered a lot of the important elements. I'll tell you something, the pioneers are the patients actually. The first angioplasty was done by Dr. Madenge, but he'd been doing angioplasty probably for 8 or 9 years prior to him doing the first one. When he did the first one, a lot of people were anxious. This guy had no option. He needed to have it done. And there was a big hospital discussion at Nairobi Hospital at the time. Eventually, he was allowed to do it, and he did it. And, you know, fast forward 20 years, and now people, I've never heard of anyone saying, oh, my angioplasty will be done in another country. If I offer a patient an angioplasty, we always get it done. So that mentality has to change, and has changed. And it's a bit like that. The development of open heart cardiac surgery in adults who don't have just pure valve disease is something that's relatively recent again. Maybe 15 years ago, people were very uncomfortable having bypass surgery done by local centers. Fast forward to now, and I think probably about 1 out of 20 patients that I recommend to have a bypass operation done by one of my surgeons in my center will choose to go somewhere else. The advantage of getting treatment done locally is very clear because you have your family around, and the local centers have a reputation to maintain. You know, if something goes wrong in my center, people in Kenya will know about it. If something goes wrong in another center in another country in the UK, very few people will sort of, you know, the reputation is not that important. But there are a few things that we can't do. And as long as you find people who understand their limitations or are interested in quality, then you'll find yourself actually sent specifically for certain types of treatments. And that's okay. It's okay to say, I don't do this. I don't operate on people's hips. I send the patient to somebody who does that. And if I don't have anyone in the vicinity in East Africa who can do it, then, you know, you might find me referring a patient to another country. But it's become exceedingly rare, and that's why you're seeing all these cath labs, cardiac centers, cardiac surgical centers blossoming. I'm not sure how many patients you've treated over the last 10 years from Kenya, but it might be an opportunity for you to explain whether those numbers have changed and whether, when you ask them, why did you come here, what the kind of reasons are.
So, first of all, at the outset, let me say that even now from India, many rich people who can afford it still go to US, UK, Singapore for surgery. So it's not like your own problem. So it's a problem every country is facing, because there is a tendency that why should I have a small Android phone? I want the best iPhone Pro. So there will always be somebody who will be better at it. And there are very few centers who can claim to be the best in the world. I can claim to be best in Gurgaon. I don't claim to be best in India as yet. And same way, like my colleague very clearly told, I fully agree with him, that we should have the humbleness to know what is our limit. And there will be demanding people who will, for right reasons or wrong, would want to go abroad just because they feel it is better. Only a specialist can tell you what is better, what is not better. If a specialist tells you that no, we have this procedure can be done in Kenya very comfortably, believe it. That's all you can do, because common man cannot decide. Common man can choose just how much money he is willing to spend, and then that's the upper limit. You know, there's no upper limit for spending more money for the procedure. As far as the patients coming to India, yeah, definitely from Kenya we are getting less and less patient. And even if the number is not less, we are getting more and more complex cases for sure. Like last patient I did came from Kenya was just last month. It's a small baby who was a hypoplastic aortic arch. So a hypoplastic aortic arch referred by a pediatric cardiologist from here only in Nairobi. And when we operated on the baby, I don't know how many of surgeons in your country would generally do a hypoplastic arch repairs. We did it. Child got, I think Dr. Deepak was the pediatric cardiologist involved. He only diagnosed the case and he only referred the case to me. And within 7-8 days, baby was out of the hospital and back to Kenya in 10-12 days. He lives in Nairobi only. So such a procedure which is not being done in your country is coming more and more. Previously we used to get simple valve cases also, simple bypasses also. That is exceedingly rare, and that's a fair assessment, I would say.
All right, in follow-up to the question, Dr. Mahash, one of the online viewers is asking, no, there are two. First question is that in terms of reducing the complications of open heart surgeries, in terms of renal dysfunction, so how common is it? and what are the interventions you take to avoid in terms of acute kidney injury post open heart surgery? Always a very broad question. Then the second one is that for valve replacement, what are the incidences of hemolytic anemia in mechanical heart valves?
Not really. I mean, both the questions, I would say, this used to be a problem of 2 decades ago. I mean, maybe that's how the evolution is. What used to be commonplace in US in 2010, we are doing in 23 right now. So there is a technological advancement. Materials are great right now. What you're using, I don't know. But renal dysfunction is practically not seen with most of the elective open heart procedures anymore. Out of 100 patients, you will get less than 1% where kidney function will worsen, and usually it will worsen because of some oversight, not per se the machine. The machines are safe. The conduct of machine, generally, if it is being done by a trained person, is excellent. Only problem happens when in ICU somebody decides to diurese that patient too much and brings about the AKI and all those things. Hemolysis also is not very common anymore, either pump related or valve related. So valve related hemolysis is extremely common if you are leaving a paravalvular leak, because against the rigid cuff, when the blood flow hits, that hemolysis will be there. But once your incidence, in your learning curve, any surgeon initially will have a lot of paravalvular leaks, and that will have higher incidence of hemolytic anemias. But as the surgeon is maturing and the pursuit is for the excellence, later in the curve, like after 4 or 5 years, if the surgeon has matured, you will not have a paravalvular leak, and then unlikely that patient will have hemolytic anemia. It's not the valve which causes hemolytic anemia, it is the inefficiency on part of the surgical steps, according to me. Yeah.
So I think just on a follow-up to the first question of acute kidney injury as a complication. So like now what I'd observed when I was in the renal unit, so we had been called by the cardiothoracic team post valve replacement. The child had rheumatic heart disease, so I'd gone for the operation, then post that developed AKI. So the debate was that how soon should we intervene in terms of dialysis? Because now from our side, the renal team, internal medicine side, we had very clear criteria of when to intervene. The cardiothoracic team believed that there was no need to wait for the overt things we look for, the hyperkalemias, the fluid overload and all that, because the patient didn't have them. So it took a while when that debate was going on for 3 days before we could reach that moment. Is there a clear reason to intervene early for dialysis for this patient if they develop AKI, or should we wait? The other challenge is that for your unit, do you have a dedicated nephrologist for your patient rather than just an overall general nephrologist who takes care of this patient?
So see, when I'm practicing nephrologist, I think it's a very good question, and it is a very common clinical problem we all face in daily life. When the system is new and the nephrologist is not seeing so many open heart surgery patients, there is a lack of understanding on the nephrologist part that in a post-operative ICU where the heart is there for any reason, if the heart was bad already or because of surgery there was some dysfunction in the heart, these patients will not allow you to wait till the classical criteria of dialysis are met. So like in a classical case, when a stable patient comes to your OPD, you will wait for potassium to rise, you will wait for urea to rise to a certain level, you will wait for the urine to drop. But if you allow such a patient in cardiac surgery ICU to wait for too long, the patient may not give you time. And that's the usual course, and early dialysis is better if you have 2-3 things. One, there is a cardiac dysfunction. If there is no cardiac dysfunction, you can wait for some more time, there's nothing wrong. If the hemolysis is extensive, then dialysis is not going to cure it. Then rather a surgeon putting extra stitch will help. He has to take back the patient to the OT and put an extra stitch. And if you feel that the kidney is a AKI, now what phase you are called in? If you are called in at a phase where you feel the urine output is coming again, where it is reviving, that time rather the dialysis will be counterproductive, because when the kidney is getting a preload and it is about to open up again, that's not the time you want to do dialysis. You want to do dialysis when the trend is worsening, not when the trend is reversing. So I think it's an individualized case-to-case basis always, and always intensivist with a good nephrologist in the long run will build a relationship where they will develop their own dynamics. Like in my ICU, my nephrologist knows until I have not called, he'll keep delayed. Once I call him personally, because he has been working with me for 6 years now. Once I call him personally, he knows it is something very serious now, that this is the final matter and we'll have to go. So daily, they'll keep waiting. And eventually when we feel, no, this is the last time and we don't have much of option beyond this, we'll personally call to the senior most person and usually dialysis is done. So that mutual understanding develops after a few failures. Unfortunately, that's the cost of learning for any unit.
Thank you. So I will take one more question from the audience, then we close. All right.
Yes. I had a question. Because of the room for you to work out during that surgery, would it be possible for you to do retrograde cardioplegia delivery? And also, what is more popular in your country? Is it antegrade or retrograde cardioplegia? And also, if you can touch on protamine reaction and heparin-induced thrombocytopenia.
So somehow in Indian patients, we rarely see protamine reaction. So protamine reaction somehow is a phenomena we see with either African or Iraqi population, where possibly fish eating is more common. In India, somehow the incidence of protamine resistance and reactions both are very less, because largely it's a vegetarian society. I think it has something to do with either the genetics or the dietary habits. So I'm not sure how it will work, because in an individual case, you have to wait. So 1 in 1,000, we will have a protamine reaction, but 0.1 is not something we are looking for regularly. And for your other question, retrograde cardioplegia can be best given if you have a large incision. If I have done a full sternotomy, it's easy to direct my retrograde cannula into the heart physically. From a small incision, it is not possible because I cannot hold the heart. If I hold the heart and direct it, then only retrograde cardioplegia will go in. So typically for a minimally invasive heart surgery, it's a antegrade cardioplegia system always. And that's where for patients where you're going to do an aortic surgery, it doesn't matter whether there is AR or not, aortic regurgitation or not. But for mitral valve surgery patients, if you try to do this surgery with aortic regurgitation, say moderate regurgitation still there or more than mild regurgitation still there, your cardioplegia may not work and you may be in a problem. That's where the case selection is very important. Aortic valve has to be largely competent when you take up for mitral valve minimally invasive surgery.
All right, thank you so much. So I'm just going to close because the time is now well spent and we have to wrap up now. The rest of the discussion, we can look for our panelists before they leave. I think they'll be waiting for us to answer more questions if you do have. So thank you so much, Dr. Mahesh. I think now you can have your seat.
Thank you.
As we honor you. So right away, I'll now call Dr. Deepak to aid me in honoring our speakers today by giving out certificates from the KMN side. So I'll invite Prof. Joey to come in front to receive a certificate. Can you clap for her as she comes? She's our mom, so you have to give her time to take her time as she comes in front. So just continue clapping for her. Then a bag. So you also have a bag for her to keep the certificate as she goes home. Next, I'll invite Dr. Bernard Samia. So he gave us a good talk on cardiovascular prevention in the era of post-COVID-19. So next I'll invite Dr. Jaylan Mohamed, also gave us a good talk on interventional cardiology techniques in adults. We can continue clapping, you should not get tired. All right. So next now I'll invite the Cardiac Society Chairman, Dr. Sabe, now to hand certificates to the rest of our speakers today. So Dr. Deepak, you can just wait. All right, let's clap for Dr. Deepak. Also give the bag so that he can carry the certificate in his bag as he travel back home. So finally will be Dr. Mahesh Madhwani, who gave the final talk. All right, thank you all. Thank you so much. Okay, so thank you so much, Dr. Samia. So I think it has been a wonderful day, which we have had a very informative discussions. So I want to take this opportunity to thank our presenters, our senior consultants, our professionals who spared their time, their busy schedule, to be with us today. So thank you so much for joining us today. I also would like to thank the audience. I know most of you have been with us for the last 3 days. So thank you so much for finding time to be with us today. All of you have your certificates, which will be awarded when we are done. I know the time is short, so we cannot take photo for everyone, but you'll have an opportunity to take your certificate before you go home, so don't hurry going home. I want to thank the organizers of this event, the KMA team, the whole fraternity. Some of them are not here today because of their commitments, as well as the Indo-African organizing committee, who has allowed us to have this 3-day conference for the last 3 days. And also the IT team, who has been here doing an excellent work to ensure that all this talk can go on with the projection. And everyone who I've not mentioned, because I can't call everyone. So let's clap for ourselves for this. And so I think I'll take this opportunity now to close this conference. It has come to an end. So you're free to walk out and also have discussion and network with your peers. All right. Enjoy your evening.
Okay. Just one announcement. I'll be issuing the certificates as you leave. Yeah. So you'll get a certificate and a bag. So he'll finish the conference, and as you leave, I'll call the names as you walk out. Yeah. I just call. So they have to pray first. They have to pray first. Prayer. Yeah. Okay. Kindly sit down. Kindly sit down. So I'll call the names and then you'll pick your certificate. Yeah. All right. So Dr. Pamela Dave, David Lumbasi, Faiz Muhammad, Grace Orina, Michael Sankuga. Thank you very much for attending. No, let them just pick them. Yeah. Here you go. It's okay, madam. Maureen Kimani, you can pick your bag there. Maureen Kimani, Masi Limo, and Gadoni Elizabeth, and Grace Wachera. Can pick one back there. Yeah. Grace, Maureen Kimani. Okay. Gadoni Elizabeth. Grace Wachera. Elizabeth and Jerry. Gadoni Elizabeth. You know, it's a large crowd. It's a large crowd. We've already started here. We've already started here. We've already started here. We've already started here. See, they can take the photographs after they've taken the certificates. That's okay. You know that it will take a long time. Elizabeth Njeri. And then Cinnamon Nyagaka. And Stephen Baru. Elizabeth Njeri, Stephen Baru, and Cinnamon. Who? Stephen Baru. Elizabeth? Yeah. Cinnamon Binyagaka. Simon Irungu, Susan Rumbia, and Alphon Kialo. Simon Irungu, Susan Rumbia. Yeah. Susan Rumbia, and Alphonse Kialo. Onyango Oluoch, Cheryl Nyacharia, and Naomi Zachary. Cheryl Macharia and Naomi Zachary. Are they here? Cheryl Macharia, Naomi Zachary, and who? Cheryl Macharia, Dr. Charity Otuoma, Dr. Mercy Cherono, and Ali Mohammed Ali.
As you pick your certificate, pass this side so that you pick your bag.
Charity. Thank you, Doc. Dr. Mercy Cherono, Ali Mohammed Ali, Dr. Stephen Gingo, Dr. Stephen Gingo, Dr. K. Jen, can I have Mr. Drew and Mr. Akbar to come help me with the issuing of certificates? Naomi Mora, Beatrice Kerubo, and Dr. Wangeshi Kanyamo. Hanif Mudadir, Swada Kasim, and Suni Abraham. James Waweru, Alio Abdikarim, and Ronnie Kosgei. Sister Teresia Onu, Sharon Kipsang, and Grace Ngala. You are? James Ray. And you? Ronnie Coste. And you? Nalim. Malim. Is Malim here? You can raise your hand up. Okay. William Kiseke. William. Soya Juma. You can raise your hand as you come. Soya Juma.
Hi, if I may just interrupt the audience, I'm sorry. I'm so pleasantly surprised that the patient just now I spoke to you about, the baby I spoke to about the audience, that last 2 weeks back only we did this arch augmentation surgery. The baby and the parents, when they knew we are here, they've just come to visit us. So happy to share and show. So Mr. Abdul Rahman and his son Abdul Manan, whom we operated, and the baby is doing very well. And I would like Dr. Zobi also to see and meet them. Thank you. Thank you.
Soya Juma. Nixon Motari and Alex Mwangi. Lavin Ogada. Lavin. Liquid. How much more? Sorry. Derek, hapana. Sijaitwa Derek. Bado. Emmanuel Busera. Emmanuel Busera. He's coming. He's there. Joan Seronei. Joan Seronei. Waweru F. Wangeshi. Waweru F. Wangeshi. Dennis Maingi. Dennis Maingi. Dennis Maingi. Moses Nzioki. Moses Nzioki. Okay, so. Wendy Kinara. Wendy Kinara. Faith Ngila. Yeah. Wendy. That's Wendy. Hawajakuja. Faith Ngila. Peter Badruddin. Immaculate Kimiri. Immaculate Kimiri. She's here. Mega Jain. Mega Jain. She's not there. Cynthia Adhiambo. Cynthia Adhiambo. Karen Cherotich. Karen Cherotich. Not there. Salome Njau. Salome Njau. Lorraine Katumo. Lorraine Katumo. Not there. Anita Bright. Anita Bright. Wambui Mburu. Wambui Mburu. Kindly pick a bag as you leave also. Don't forget the bag. Wambui Mburu. Mutia Simon. Mutia Simon. Francis, Dr. Francis Carr. Dr. Irene Otiato. Jesse Wanyiri. Zephania Mbatia. Zephania Mbatia. Osodo Cynthia. Mary Wangui. Mary Wangui. Can we kindly have Faiz Mohammed to join us kindly? Achieng Lavenda. Laventa. Achieng Laventa. Come back. Thank you very much. Lilian Nakumicha. Lilian Nakumicha. The other one. So. Juliet Akinyi. Juliet Akinyi. Brian Makuto. Brian Makuto. Josephine Kata. Josephine Kata. Dr. Nicholas Misigo. Dr. Edward Jahaka. She's coming, she's coming. Joseph Gichui. Joseph Gichui. Alvin Mwasasi. Alvin Mwawasi. Edward. Or Dr. Edward Jahaka. Dr. David Mungai. Dr. David Mungai. Gideon Nyakundi. Gideon Nyakundi. Dr. Simon Kigondu.
I can receive.
Okay. Dr. Dismas Kazimoto. Dr. Simon Kigondu. She's taking on behalf of Dr. Simon Kigondu. Nancy Charity. Nancy Charity. She's not there. Dr. Peter Mbugwa. Dr. Peter Mbugwa. Dr. Rodney Kipiegon Mutai. Dr. Eric Boaz Kipkorir. Eric. Dr. Wendy Kinara. Wendy Kinara. Dr. Wendy Kinara. Dr. Boniface Omondi. Skajes Ngugi. Skajes Ngugi. Boniface. Evans Vuseno. Evans Vuseno. Victor Ngatia. And James Kioko. Victor Ngatia. James Kioko. Victor is there. James Kioko. Yeah. James. Catherine Moimet. Catherine. Yeah, she's coming. Natasha Mudhuri. Natasha Mudhuri. Charles Chajira. Charles Chajira. Charles. Maureen Kimani and Lavin Ogada. Maureen Kimani and Lavin Ogada. Georgina Waringa. Brian Clinton. Who? Georgina Waringa. Brian Clinton and Owino Sarah. Owino Sarah, Navil Frank, Atieno Michael Sila, and Oroni Phineas. Oroni Phineas. Okay. Ivan Sydney, and Derek Amusavi. Caroline Mwaniki. Mr. Derek, Derek, I've not called Derek. I've not called Derek. Correct. This one is? I guess so. Oh, Derek. And Derek. Langiai, Eric Langiai. Oh, sorry. Ian Panika and David Nyabola. And Wayne Omondi. David Nyabola, Wayne Omondi. Wayne? Okay. Mark Ambido, Emmanuel Kosgei. Mark Ambido, Emmanuel Kosgei. Emmanuel Kosgei and David Mogaka. David Mogaka, Jafet Omweri, and Tiffany Langat. David. Jafet Omweri, Tiffany Lagat, and Sophie Oguta. Tiffany, this one. Yes. Sophie Oguta and Jafet Omweri. Angela Maera, Kinya Nina Gitonga, and Milton Macharia. Angela Maera, Nina Gitonga, and Milton Macharia. The one. Samuel Obiero, Joel Musindato, and Nina Gitonga. Dr. Crystal Serena, kindly join us. Samuel Obiero. To give certificates, and then you can relieve you. Okay. Faiz, you can just.
Another one is coming over. No. No, wait. Faiz.
Thank you, Faiz. Thank you very much. Kenya. May I have Isaac Omondi, Gabriel Chawana, and Bradley Mwendwa. Gabriel Chawana. And Bradley Mwendwa. May I also have Clement Oluoch, Gertrude Wairimu. Bradley. Gertrude Wairimu. May I have Anita Bright, and lastly Elizabeth Kavithe Ngato. There are some names I called, and they didn't, maybe they didn't hear well. So there are some certificates left here. So thank you for coming to the. Yeah? Thank you so much for coming to the Indo-Africa Congress. We appreciate your attendance.
So sorry, let us pray first.
Kindly, let us pray first.
Then let's pray first, then now we'll
the rest of the certificates will be handed over.
You'll get your certificates and your bags.
Kindly. Let's pray first. We'll issue the certificates.
Do you know some of you are going to sort out? Huh?
Kindly.
Let's pray, then you are going to sort out everything when we are done. Huh?
Yeah.
Kindly. So just have your seats, then we sort everything. Kindly.
So can we have
Come and pray for us. Yeah. Then the rest we are going to sort you out, so don't be worried. The bags are enough, certificates are there. So just go back and have your seat. All right.
So, may we rise and pray? We pray in the name of the Father, and of the Son, and of the Holy Spirit. Amen. Dear Lord God, our Father, we thank you for the opportunity that you have given us to be enriched today through the conference that has happened today, yesterday, and the day before. We ask your blessings on all those who have contributed, and we ask you, O Lord, to continue to be with us and help us to be better carers for all those who need our help. This we pray through Jesus Christ our Lord. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you.
Anita. Odhiambo Jama. Lavin Ogada. Victor Ngatia. Wendy Kinara. Dismas Kazimoto. David Mungai.